Health Noida. We extend a warm welcome to all of you who have has joined in today, both as faculty as well as delegates. And first and foremost, a very happy International Thalassemia Day to all of us. And as people who have been involved in the care of thalassemia patients, we have seen how treatment has changed over the last few decades. And when I was doing my post-graduation and further training, we have seen children who were really moribund by the time they were in the end of the first decade or early second decade. From those years, we have come a long way. We now see children who get into professional courses, who are getting married, who are having children of their own. And that has all happened because of the extensive advocacy efforts that has been done by the doctors as well as the patient organizations who have been involved in care of thalassemia patients. So a big thank you to all the people who have worked behind the scenes and in front of the scenes for this to happen. And I think in the PHO chapter also, there's a lot of activity today. And you must have people who have members of the pediatric hematology oncology chapter would have already seen the videos being circulated with in collaboration with the Ministry of Health and Family Welfare. So I welcome you all from our side, and I would request Srimati Shobha Tuli ma'am, who's joined us. She's the Secretary of Thalassemics India. She's a founder member of Thalassemics India, one of the major national NGOs which is involved in the care of thalassemia patients. And she's also the Secretary of Thalassemia International Federation. I would request you, ma'am, to speak a few words. Over to you, ma'am.
Thank you, Dr. Neeta, for your kind words. So a very good afternoon and good evening to all of you. As Neeta had already said that today is World Thalassemia Day. And I'm very pleased and I want to share with you, and I'm sure that you all must agree to this point, that I have never seen so many programs and activities being done in our country on World Thalassemia Day. So I feel this is something, a progress is being made, and all credit goes to our doctors, hospitals, and the NGOs. So I want to, on behalf of the organizing committee, I welcome you all to this very important webinar. I have been told that nearly 400 registrations
This meeting is being recorded.
Taken place, and not only from India, but also from our neighboring countries. We all know about that. I don't want to talk about what has happened earlier, but now today's topic of this webinar is treating thalassemia in India and setting standards of care. This is the recent topic for deliberations by the experts who are here. So I would name them, each one of you personally, and some of them are, I will say that they are my teachers. I have learned a lot from them. And I think today's deliberations and today's webinar will also is another opportunity from where I will go back home, learning some new things. So Honorable and very respected Dr. Jagdish Chandra ji, Dr. Tulika Seth, Dr. Anju Seth, Dr. Neeta Radhakrishnan, who's the organizer and the person behind this webinar, Dr. Vikas Jain, Dr. Satyam Arora, Dr. Achit Pandari Pandey, Dr. Silki Jain, Dr. Anju Singh, and Dr. Subhash Chandra. I welcome each one of you. मुझे याद है कि जब हम सुनते हैं हॉस्पिटल में हो या और पेशेंट से सुने या थैलेसेमिक पेशेंट से, दे ऑल से कि डॉक्टर्स हमारे भगवान होते हैं. जब कोई बात बिगड़ती है तो all these people, patients and their parents, including thalassemia families, they look upon you as their gods. So I feel that today on this World Thalassemia Day, I would re-stress that, well, without your cooperation, without your support, and what science has progressed, that thalassemia where it is today, I couldn't have at least dreamt of that we will reach to this stage where we will be talking about the uniform health system in our country, where we'll be talking about the prevention, where we'll be talking about the cure, and of course about the gene therapy and the newer drugs also. And today I'm very happy to learn that this topic, because some of the case studies are going to take place now, and it's really done in the webinars. So I congratulate Dr. Neeta Radhakrishnan and others, for preparing this program. And on a personal note, I once again welcome all of you, and I wish all the participants a very happy International Thalassemia Day once again, which is celebrated in more than 94 countries across the world. I remember that day in 1994 when I had a conversation with Thalassemia International President Panos Anglosas, when this day was declared by the ministry, that let's get this day declared so that the message, and every year the new theme is given. So I'm very happy that whatever, there is a story behind that, which I will not discuss it here. But what I look at that, I always look at the positive side. So the positive side is that this day gave us a day, a time where we all NGOs, all the doctors contribute something or the other, and that is always towards the care and cure of our patients. So let's make this day a very special one, and I'm sure today's webinar will be a step forward to move forward to get the uniform where we want to reach, which is our vision. And I'm sure you will agree to this, that any NGO who is working in this country, vision is that we want to have the uniform standard care, for our country, because thalassemia is a progressive disease. And we all know that without the government support, we cannot achieve further. Dr. Neeta Radhakrishnan has already briefed you about a video which was released today by the Health Secretary. I was present there, and Madam Anuradha Patnaik ji was also there, Harsh Mangla ji was also there. So this is another attempt by the expert doctors who are involved in this video to raise awareness. So ministry and the governments, we always look upon for that, and for which so many doctors are involved into that. Lastly, I would thank ECO for giving us this platform, and the ministry also, the NHM also, and all the health authorities who are present there. Thank you very much once again for taking your time to be here and to share your views and to start with this program. Thank you once again for giving me this opportunity to welcome the experts. I will say Bhagwan, I will say the stalwarts, and I really respect you all. Thank you so much.
Thank you very much, ma'am. So we now go on to the first session of today's webinar. So now we have a talk by Dr. Jagdish Chandra. Dr. Jagdish Chandra is one of the most senior-most pediatric hematologist oncologists in our country today. And sir is currently serving as professor and head of Department of Pediatrics at ESI Medical College and Hospital, Faridabad. And all of, as in sir does not require any introduction, sir has been previously director of Lady Hardinge Medical College and has served as professor pediatrics and was in charge of the pediatric hematology oncology services as well as HIV services at Lady Hardinge Medical College for a very long time. And sir has been co-chair of the Indian Academy of Pediatrics Guidelines on Thalassemia, which was released again on the same day last year. Welcome, sir, to this talk, and sir will be speaking to us on standard of care in thalassemia. Over to you, sir.
Thank you, Dr. Neeta, for those kind words, and my compliments to all the participants as well as all patients on this Thalassemia International Day. And I wish that the patients enjoy good health, and we too have continued endeavors for the better management of these patients. So I thank for giving me this opportunity. My slides are seen now?
Yes, sir, your slides are visible.
Okay, so next 25 to 30 minutes, I would speak on the care of the thalassemia patient. So just to highlight that the carrier status in India as on 2011 census of India, there are almost 35 to 45 million carriers of beta thalassemia in our country, and to highlight that out of the 30,000 children born with beta thalassemia major worldwide, we have a major share is that is 10,000, 12,000, and this figure is almost the same for last three and a half decades. It has not changed despite the efforts in the direction of prevention of the condition. And just to quickly look at how do these cases present, they present uh, the patients with thalassemia major would present with anemia and hepatomegaly. Most of the TDT patients would present between 6 to 24 months of age, but 5% cases may present earlier than that, and some 10-15% cases beyond the 2 years of age, which is the usual age between 6 to 24 months. And typically, these patients are brought that the anemia is not responding to hematinic syrups. So we look at the blood findings, and typical findings include the microcytic hypochromic anemia with lot of anisopoikilocytosis, nucleated red cell precursors, and obviously the red cell indices are low MCV, MCH, MCSC, and increased RDW. The diagnosis comes from HPLC, which showed elevated HbF, maybe somewhere between 45 to 90% or even more at times. So, if the child has already received a transfusion before being brought to the center where we are investigating, there might be problems. In such cases, we have to wait for 6 to 8 weeks after the last transfusion, and then we repeat the HPLC. Meanwhile, we can investigate the parents with CBC and HPLC. If both of the parents are carriers, that is, the elevated HbA2 is there more than 3.5%, which would mean that a child with hemolytic anemia whose both parents are carriers of beta thalassemia, most likely we are dealing with beta thalassemia. We may also do the molecular diagnosis. In fact, in the current era, one should go for the molecular diagnosis in each and every case. Of the over 125, 130 mutations, there are 28 mutations which are identified in India, but 6 of them are responsible for over 90% of the cases, which are listed here: IBS 1511, codon 89, etc. And when the testing is required, we mostly initially do for these 6 mutations. So clinical severity of thalassemia, we look at if the patient is homozygous. There are two presentations. One is thalassemia major, which currently is labeled as transfusion-dependent thalassemia. And these are the patients who have rapid fall of hemoglobin and they need transfusions for sustaining their life. The other cases who are homozygous, but they do not have that rapid fall of hemoglobin, and they are called thalassemia intermedia or non-transfusion dependent thalassemia. There mostly the hemoglobin gets maintained at about 7 gram per deciliter without any transfusions unless there is infection or some other stress. The heterozygote state obviously is beta thalassemia trait. We call them thalassemia minor or carrier, which includes even the silent carriers of thalassemia. So how do we decide whether the patient is thalassemia major or intermediate? Maybe typical presentation might help us, but uh, the the labs might tell you that the levels are 45-50%. So the diagnosis is beta thalassemia major, but it's not always. You can see that mostly the HPLC shows HbF 40 to 90% in thalassemia major, but 15 to 50% in intermediate. So there might be an overlap also. So the best criteria in difficult cases is to look at the fall of hemoglobin, which in thalassemia major would be 1 gram per week or more HB fall. So most thalassemia intermedia would have a smaller fall unless there is some infection or some other stress. And in such situations, at times we might the patients might take 3 to 6 months also before settling down. So this might be difficult cases, and it is always important if the patient has presented at a unusual age beyond 2 years or so. We have to be very careful in assigning the severity, whether it is TDT or anti-DT because of something else the patient has presented with acute anemia. So now moving on to the treatment of transfusion-dependent thalassemia. So after confirmation of the diagnosis, we sit down with the family and tell them about nature of the disease, that it is genetic and what are the chances of recurrence in subsequent pregnancies, what is the cost of treatment and the need for compliance to the treatment. And the treatment that we can offer them are the curative treatment in the form of stem cell transplant and the palliative treatment, which includes the transfusion, iron chelation, and monitoring. And we will also discuss the HPF inducers, which is the talk of the day these days regarding the thalassemia patients. So, as Dr. Neeta mentioned, last year on this date, the thalassemia guidelines were released by the DG ICMR, Dr. Rajiv Behr, and the most of the recommendations that I would be talking about would be from these guidelines. So, coming to the transfusion therapy, we have to look at who, why, when, what, how, and how much to transfuse. This all we will discuss, and what are the reactions, etc. So transfusion dependent patients, they would need regular transfusions. Sparingly anti-DT patients also might need in cases with infections or other stress and growth related issues. If there are extramedullary hematopoiesis masses which are causing compression symptoms, in those cases as well, we need to give them regular transfusions. And thalassemia patients, if they have decided to undergo transplant, even then, by the time the transplant would be done, there would be a few months to uh, time, and during this also the patient would require regular blood transfusions. So why these TDT patients need transfusion is because anemia results in poor tissue growth and resulting in growth failure, and anemia and ineffective erythropoiesis leads to marrow expansion with lot of skeletal abnormalities. Fortunately, with good treatment, these figures, the photos and radiological picture have become thing of the past in most situations. There is extramedullary hematopoiesis with liver and spleen enlargement in absence of a regular transfusion. And obviously, if the patient is anemic, there would be increased iron absorption, and there might be poor iron chelation, again leading to a lot of complications because of iron overload. So when to start? That is when the diagnosis of thalassemia major, that is TDT, is confirmed, and in some cases, particularly the anti-DT, clinical criteria are there irrespective of the hemoglobin levels. So if the hemoglobin is even more than 7 with any of the following, like the facial changes or poor growth, for that poor growth, one has to look at the other causes, and if one the doctor feels that the poor growth is on account of anemia, then the patient has to be put on regular transfusions. Fractures and clinically significant extramedullary masses, these are the indications for regular transfusion of the patients with anti-DT. What to transfuse? That is packed red cell, and they should be tested negative for hepatitis B, C, HIV, syphilis, and malaria. And net testing is talked about, and this is better because the window period becomes very, very small. But unfortunately, it is limited. Even today, it is limited only to the larger cities, that too in only some centers. Typically described, the blood should be fresh, but less than 14 days is good enough. One can give that, and it should be leukodepleted blood and extended cross match, or at least better matched blood. So what are these leukodepletion? uh, Reduced white blood cell in the blood unit, that is what is called the leukodepletion. And the proper leukodepletion is considered if leukocyte content per unit of the blood is less than 5 into 10 to the power 6. There might be some other criteria also, because across European and American Academy of Blood Banks, the criteria are different. And the blood unit must have retained at least 85% of the original red cells. So how do we do the leukodepletion? There are several methods, but pre-storage and bedside filtration are the common ones, and mostly centers are using the filters, bedside filters. But a pre-storage filtration is better, because the if the time span between blood collection and leukodepletion is shortened, the leukodepletion is better. And because during storage also, leukocytes degranulate and fragments, releasing cytokines, especially interleukin 8, and that results in febrile and allergic transfusion reactions. So pre-storage, that is done in the blood bank, that is better, but bedside filtration is commonly being practiced at the present time. So these are the filters. And the advantages of leukodepletion include reduction in febrile reactions, reduction in CMV and CMV transmission risk, reduction in transfusion-associated GVHD risk, reduction in variant Creutzfeldt-Jakob disease transmission, and better outcome of stem cell transplant. There is reduction in platelet refractoriness if the patient has been given only leukodepleted blood. Next is the cross matching. The usual cross matching is done for ABO and the RH blood group, but better matched is when matching for all RH and Cal antigen, that is small c, capital, small e, and capital E and K, along with ABO and D antigen is done. But partial better matched is in our country, this is regarded as good enough because in Asians, the prevalence of these antigen is there, but the variability is not as much as it is there in the European countries or in America. So a partial better matched is also effective strategy, and there is some data from Lady Harding where I was working earlier. The studies have shown that the partially better matched patient do much better because they do not develop illumination and alloantibodies as frequently as the patients who have been given only RH and ABO matched blood. How much blood should be given? That depends on the clinical status of the patient, but mostly one has to remember that 5 ml of packed RBCs per kg will raise the hemoglobin by 1 gram, and there is fall of hemoglobin by 1 gram per week in these TDT patients. So, if you maintain a pre-transfusion hemoglobin of 9 to 10.5, that is a recommendation mostly. Transfuse 12 to 15 ml per kg body weight to raise the hemoglobin by 3 to 4 grams. And so the hemoglobin post-transfusion is targeted at 13 to 15, though it's not recommended that every time the patient should undergo a post-transfusion hemoglobin estimation. No diuretic is given routinely, but in cases where the hemoglobin is low, that is less than 5 gram, or there are cardiac problem because of the cirrhotic cardiomyopathy or because of anemia, then a small amount is given. Maybe it can be repeated 1 to 2 weekly. There again, the diuretic would be required, and here the blood is given slowly, 2 ml per kg per hour, and the total volume in one sitting is not more than 5 ml per kg. So that's the usual recommendation in cases where there is cardiorespiratory decompensation because of anemia or because of the cardiac cirrhosis. So it's preferable that the transfusion is given in a separate area. There is the daycare center where the patient is given the transfusions, and the time loss and inconvenience should be minimized. The staff there is familiar and the nurses are familiar. Maybe there is some form of entertainment available in the thalassemia daycare center, and of course the nurses do impart some education regarding the diseases in thalassemia daycare center. Moving on to the iron chelation therapy. The sources of iron in these patients would be the transfused blood, continuing hemolysis, ineffective erythropoiesis. In fact, this is the major component, and increased iron absorption, particularly if the hemoglobin is not maintained well. So these are just stats about how much blood is the iron is there in one blood unit. Roughly 200 milligram iron is there in one blood unit. That is of 420 ml, and the patients of thalassemia who receive 100 to 200 ml per kg per year pure red cell, they would receive 116 to 232 milligram per kg per year iron, and there is no mechanism in the body to excrete extra iron, so therefore the iron chelation is required. Otherwise, this gets deposited in the body and leads to the organ dysfunction. And gastrointestinal hyperabsorption could be there. It might increase to from 1.1 to 2 milligram per day to 3.3 to 5 milligram daily in poorly transfused patients. And in thalassemia intermedia, this might be 5 to 10 times of the normal because they are generally left without transfusion. So hemoglobin is hovering around 7 or 8 gram only, and therefore they absorb the iron more from the and the pathogenesis of iron toxicity is mostly related to reactive oxygen species. So, how do we assess the iron overload? That is, mostly we do serum ferritin. Cardiac iron MRI based assessment is recommended from the age of 7 to 8 years in our guidelines. In fact, this age is basically at what age you can get the cooperation from the patient, because the patient has to hold the breath to get the proper estimation by the MRI. Liver iron also consultation MRI base can be done, and NTBI, urinary iron excretion. These are the other methods, and of course indirect observations in the form of organ dysfunction. So serum ferritin has an advantage of being easy, inexpensive, and can be repeated frequently. Broadly, it correlates with body iron stores, correlates with morbidity and mortality, and this is an old figure of less than 2500 nanogram per ml on long-term basis is associated with a significantly lower risk of cardiac disease and death. And this 2500 nanogram is certainly not acceptable even at the present time. But limitations of serum ferritin are that it's an indirect measure of the iron overload. It fluctuations in response to inflammation. It decreases in vitamin C deficiency, and it is estimated that above 3000 nanogram per ml, the serum ferritin does not correlate too well with the body stores. And it underestimates iron overload in thalassemia intermedia. So, MRI based assessment, let me see if I can have a pointer. All right. So, the left panel shows you the normal heart and liver. And here the heart is more iron overloaded, the liver is not that much. And the right side, right side, the liver is more iron loaded and the heart is not that much iron overloaded. So MRI assessment is done to know what is the status of iron overload in these two important body organs. As far as availability of chelators is concerned, we have three chelators available: despiroxamine, deferiprone, and deferasirox. And these are the properties of these. But most importantly, we should look at the lowest row, where one look at the elimination half-life, that the DFO has 5 to 10 minutes. That means it has to be given as a continuous infusion. Deferiprone has 1.5 to 2.5 hours, and this also requires multiple doses in a day, that is 3 doses. And deferasirox has 12 to 18 hours, and one can manage with just one dose daily. And the deferiprone and deferasirox are oral compounds. So the DFO is administered subcutaneous injection by infusion. The deferiprone is oral thrice a day, and deferasirox is oral once daily. So how do we begin with chelation therapy is that the first serum ferritin is advised after 10 to 12 blood transfusions have been given. If the ferritin is found to be more than 1000 nanogram, the chelation is started with the ferrosirox 20 milligram per kg, because this is a drug chosen because this is the ease of administration in young children, dissolved in water or juice, better tolerated. And after this dose is started, we should monitor for the response and adverse effects. Increase the dose by 3 to 5 milligram per kg if ferritin is increasing. And when you have reached a ferritin of 700 persistently, it is 700 or less, then one can reduce the dose 10 to 20 milligram per kg. In fact, closer to 10 rather than 20 milligram per kg. And one should keep monitoring whether the ferritin now persists in this range itself. The film coated tablets have become available. Deferasirox FCT has become available, and it can be swallowed without any, it's not to be dissolved in the water for consumption. The treatment compliance by pill count has been seen that with FCD is much better, 92% or rather 93% compared to 85% with the dispersible tablet. But the recent studies have shown that probably in younger children, the outcome with FCT is not all that great as it is in older children and adolescents. Combination chelation is required when the serum ferritin is persistently above 2000 nanogram per ml, or there is MRI-based evidence of iron overload in liver or heart, and that cannot be taken care of with one drug. So a combination of deferasirox and deferiprone is easiest and most cost-effective way to reduce iron burden. But in cases where the faster iron removal is required, one can give deferasirox with desferoxamine or deferiprone with desferoxamine. So the infusions of desferoxamine can bring down the iron overload from the heart or liver faster compared to the two drug given orally. Now, moving on to the monitoring the thalassemics, we need to monitor the transfusion-related issues and related to the iron overload. So, why we need to assess the transfusion adequacy is that because we looked at why patients are requiring transfusion, so we should see that transfusion is providing adequate tissue oxygen and the proper growth of the patient is there or not. It should keep the erythropoiesis under check so that there is no bone marrow expansion and there is no hepatosplenomegaly. And obviously, this will delay the splenectomy in these patients or avoid splenectomy. Absolutely. So, the growth need to monitor by weight and height and then monitor on the charts. And let us look at the transfusion transmitted infections at least every year or maybe 6 to 12 months. And if the patients are found to be positive, I think there are cases in the discussion, so I will not go into the details into this. The iron overload related monitoring requires ferritin every 3 months. Adjust the chelator dose. May need to consider adding second chelator as we discussed earlier, and T2 star imaging, MRI imaging after 7 to 8 years of age. So, what ferritin level is maintained? That is, now the figures are changing. The 2500 are the old figures, and the ferritin level should be kept under 1000 nanogram and preferably under 700 nanogram per ml. And actually, our recommendation say 1000, but most of the newer literature has come up with 700 nanogram per ml. A level of 500 nanogram per ml is also recommended in some of the newer literature. Then we monitor for organ dysfunction, growth, as we discussed, cardiac status after 10 years, endocrine dysfunction, diabetes, gonadal dysfunction, pivotal assessment every year after 10 years of age, and hypothyroid. And psychological evaluation is very important because you might be giving good transfusion, adequate transfusion, and the patients are adequately chelated, but there are issues related to the disease and its treatment. And because of those, there might be psychological problems, and that might lead to the non-compliance with the treatment. So, evaluation is important, and they require frequent evaluation on a structured performa and may need psychologist or maybe psychiatrist intervention at times. One should keep the record of these patients and their visits. So after the transfusion, chelation, and monitoring, let us move on to briefly about the HbF inducers. Mostly we talk about hydroxyurea, but the latest Cochrane database systemic review says that there is no high quality evidence to support or challenge the continued use of hydroxyurea. But overall, very few patients respond to hydroxyurea. This is regarding transfusion dependent. Anti-DT, of course, the patient do get some increase in hemoglobin, and they are mostly treated with. There is a lot of literature now available on thalidomide. And thalidomide, we also found in one study that in about 50% patients, there was more than 50% reduction, and another 30% patient had reduction of transfusion needs between 25 to 50%, and it was found to be fairly safe in this small study of 6 months. Then we just completed a study in which low and standard dose, that is almost 1 milligram per kg versus 2 milligram per kg dose, was compared. And the low dose thalidomide was also found to be as efficacious as the standard dose, and we found a response in 56% of the patients with the reduction in transfusion needs. The other drug which is available now has become available for almost 1 year or 15 months is luspatercept. Is an expensive drug. It's given subcutaneously every 3 weeks, and the figures for transfusion reduction, they are much poorer compared to what the thalidomide does. They almost 1/3 or quarter of the patient they have the reduction in the transfusions. And if you look at the number of transfusions reduced 2 units RBCs for 12 consecutive weeks, that means out of this is for adult patients. So out of the 12 consecutive weeks, that means for 24 units, only 2 units reduction, that was the criteria, and that too was fulfilled by 1/3 of the patients. So as of now, this drug is approved only for adult thalassemics, and generally the dose begun is with 1 milligram. It could be increased to 1.3 or even up to 1.75 before discarding that this dose is also not effective, and one should use almost for 3 to 4 months before saying that it is not effective. All this treatment should be provided in comprehensive thalassemia daycare center, which has improvement in the form of improved mean pre-transfusion hemoglobin. This is the data from the Thalassemia Daycare Center of Kalavati Children's Hospital. So you can see that the hemoglobin, which used to be around 6 to 7 grams, it's improved to in the vicinity of 10 grams and across all the age groups. The ferritins, high-rise buildings of ferritin, one could see that they are now not seen now. And with this comprehensive care, one can see that there is improvement in survival in our country, and small data on 500 cases, we had 43% who were above the age of 18 years. And you can see here that of these above the age of 18 years, mostly are more than 25 years of age. And they are, as Dr. Neeta mentioned, they have undergone professional training, post-graduation, graduation, and many of them are employed or self-employed. And therefore, the adult patients need to be transitioned to the adult care settings. And of course, this requires a team effort. So with this, I think I would end by acknowledging the people who helped me. Thank you very much for your kind attention. Over
Thank
to
you,
you.
sir. Thank you, sir. So I think we'll start with the question since sir has to leave after this session for another talk today. So we are requesting anyone with any questions regarding sir's talk, any doubts, to kindly share their questions in the chat box. So we have one question, sir, regarding from Dr. Naresh Tade, regarding side effect of thalidomide and how much period can thalidomide be given. Over to you, sir.
Okay, so first thing is that thalidomide should be given only under steady conditions, because it is not approved for this indication in our country. The studies that we have done over the last 3-4 years, they have been with the approval of DCGI. Now, as far as the duration that can be given, the latest data shows that 4 to 5 years also the patients have been given, and it is fairly safe drug. Now, the adverse effect reported constipation and somnolence. These are two adverse effects commonly reported. Somnolence can be taken care of by giving this drug in a smaller dose to start with, and that too in the evening. And constipation is something which was like not very troublesome in most of the patients. An occasional patient had a severe adverse effect in the form of polyneuropathy. So one has to be careful regarding use of this drug. That is why I said till the drug is approved for this indication in our country, we should not be routinely prescribing this drug. Though I am aware that several studies have been published on the use of the thalidomide from our country. Many centers are using.
Yes, sir. Thank you, sir, for clarifying that. There's another question from Dr. Abhilasha. How often should cardiac MRI be done after 7 to 8 years of age?
Okay, so that would depend on what is the status actually. If the cardiac status is fine, like there are no symptoms and the cardiac MRI shows that the values are acceptable, 18 to 20 milliseconds, that is the normal. So one can do it after 2 more years. If it is found to be uh, in the suggesting iron overload and you need to monitor, you need to increase the dose of iron chelators. So then you would like to do quickly, maybe at 6 months. At least 6 months time should elapse after you have increased the dose, then only the effect would be seen. So one can safely say that the initial MRI report will decide how often you need to do it.
Thank you, sir. There's one more question. How would you manage heavily aluminized children when matched PRBC is not available?
Anybody's guess what would be done. So we need to give the drugs, though they are not very effective, but say corticosteroid or IG can be used in these patients. And the what do they say, least incompatible blood, that could be given to these patients. And say 6 to 7 gram hemoglobin. One should not rush with these patients too much of blood, because they might be anemic and they might be having cardiorespiratory distress. But these are difficult situations to manage, and there's not much data on the use of plasmapheresis, but theoretically that can be used for in cases where there is the IVIG and methylprednisolone, or a combination of these has not worked, and the units are not easily available.
So two more quick questions, sir.
Yeah.
One from Dr. Joshi Karketa on the role of traditional medications. Wheat germ, I think wheatgrass is what Dr. Joshi is trying to ask. And Dr. Joshi says they are seeing children with stroke. How can it be prevented?
Okay, so wheatgrass juice therapy was tried some 15-20 years back by there were studies. One was reported from PGI Chandigarh. Only some response was there, but the very fact that that center is not using and no one else is using, it's probably not very effective. Some people tried giving wheatgrass juice tablets, which were imported from US, and even that did not show in the study much improvement, so that was given up. That is regard one. The second is stroke. Okay, so the strokes do occur in these patients. They are, in fact, all hemolytic anemias are prothrombotic conditions, and so are the thalassemics. And in these patients, one has to see if it is arterial stroke or venous stroke, and the thrombolization is required or not. And after that, if it is arterial stroke, maybe one can put them on aspirin. And if there are risk factors, like if the patient has been splenectomized and they are having thrombocytosis and lot of reticulocytosis, in such cases chronic prophylaxis needs to be given. Maybe at times, if the major venous thrombosis has occurred. Stroke means, I thought maybe they are talking of the cerebral strokes. So the warfarin is not probably required in those situations. Just giving aspirin would help.
Thank you, sir. We'll take questions which we are not discussing later. So one question is on a role of L-carnitine and NAC in addition to chelators. Does it reduce oxidative stress?
Well, these are all experimental therapies, and as of now, there is not much data on them. I am not aware of any recommendations using them routinely. There are other as well. The glutamate has come up, and then what is that which increases the pyruvate kinase levels? That compound, I'm forgetting the name. So these drugs have come up, but they are like experimental still. And mitapivat, that is also people are using in thalassemia, but these are not, as of now, they do not have a defined role in the management of thalassemia.
Mitapivat congeners are in trial now. for both
Yeah.
thalassemia and
Yeah.
sickle.
Yeah.
Can moderate iron overload be completely reversed by chelators?
Oh yes, iron overload can be when the chelators arrive, particularly when deferriprone arrive in addition to desferoxamine. There are studies from US that the cardiac cirrhotic patients who were having cardiac symptoms and they were reversed with the use of both drugs, because we know that the deferriprone is a better chelator from the cardiac iron, and desferoxamine, both combinations they were using. This can be, there are studies in which they have shown that even the endocrine dysfunction patient, their endocrine dysfunction reverted after the combination therapy was used to reduce the iron overload. Certainly the iron overload can be reversed, and even the organ damage that has been done, partly that can be reversed with the use of the effective chelators.
Thank you, sir. There are some questions. There are some requests whether you could share the PPT that we'll discuss with sir, and the recording of this.
I can share it with you, and you can share it with the audience.
We can share it, and even the recording will be shared. So the
Yes.
entire session is being recorded by ICO, so that can be shared. There's one last question, sir. Role of
Sure.
aspirin in TDT.
Role of aspirin.
Partially replied already.
Yeah, partially replied. And actually, see, thrombotic tendencies are there, but as of now, it's not routinely recommended, even if, like we say, that the patient is at the increase. As a secondary prophylaxis, yes, it is recommended. There, though, in patients with only a few days back, I came across one study where they have used thalidomide, and in addition to that, they gave aspirin, because Nita, you might be remembering, even we were discussing whether
Yes,
to
sir.
give it routinely. So we didn't give it routinely, but they used it in adults, and they have given it routinely, because that again is a prothrombotic drug. So as of now, we do not use it as a prevention, but secondary prevention, yes.
Thank you very much, sir. And I think
Thank you.
thank you very much for that exhaustive discussion on entire management of thalassemia in like 20 minutes.
Yeah, I didn't know whether diagnosis, etc., is being discussed, so I thought I'll spend a couple of minutes on those also. Thank you so much.
Thank you very much, sir. And I request you to be in the group as much as possible, sir. I know you have to attend another meeting. So now we go on to the panel discussion for today. So again, for those of you who have joined late, is it coming? It's not shared. So those of you who have joined late, welcome to today's session on thalassemia setting standards of care. And this program is being done in association with the National Health Mission. So we are a state government institute in UP, and we get support for diagnosis and management of thalassemia through National Health Mission. We are also collaborating with Thalassemics India, with Academy of Pediatrics Noida, and ECO India for this webinar today. And welcome you all again to today's webinar. And we just heard from Dr. Jagdish Chandra on the standard of care in thalassemia as of today. Now we go on to a panel discussion. We have deliberately selected difficult cases in adolescent children, because as you all know, diagnosing thalassemia and managing the initial part of thalassemia is usually discussed again and again in forums. And then I always tell parents also that when they start treatment, the first 5-6 years of treatment is not, it's usually just mathematical calculation. So you come with a hemoglobin, you transfuse, you send them home. And even chelation is again, just start chelation after 10 transfusions, chase ferritins, and it goes on and on. But it's after like 6-7 years of age that when the problems actually start setting in. And then by the time there are 10 to 15 years of age, you have a whole lot of issues that come in. So that's what we are going to be discussing today in the panel discussion. So we have esteemed panel of masters today with us. I would like to introduce one by one to you. We have Dr. Tulika Seth. Professor Tulika Seth is professor in the Department of Clinical Hematology at All India Institute, Delhi. Welcome to the program, ma'am. And ma'am's special interests are disability guidelines. Ma'am has been chair of the disability guidelines for hemophilia, thalassemia, and sickle cell anemia which has been released through the ministry or the government of India. Ma'am has also actively worked in thalassemia, sickle cell anemia, and has been chair of committees for guidelines in thalassemia as well as sickle cell anemia. We welcome you, ma'am, to today's session.
Thank you. Thank you.
We have Dr. Revati Raj. Dr. Revati is Senior Consultant and Head of Pediatric Hematology Oncology and BMT Services at Apollo Hospitals, Chennai. And ma'am has one of the largest experience in bone marrow transplant for children in the country. And her special interests are transplant for thalassemia and primary immune deficiencies, childhood leukemia, and novel therapies like haploidentical transplant. We welcome you to today's session, ma'am. We are joined by Dr. Satyam Arora. Dr. Satyam is additional professor in the Department of Transfusion Medicine here in our institute. His special interests are neonatal and pediatric transfusions, BMT and cell therapies. We welcome Dr. Satyam.
Thank you, ma'am.
We are joined by Dr. Anju Seth. Ma'am is Director, Professor and Head and in charge of the Division of Pediatric Endocrinology at the Department of Pediatrics, Lady Hardinge Medical College, Delhi. And as you all know, in thalassemia management, it's very, very important to have a multidisciplinary team along with you. And endocrinology being a very, very important part of management of especially adolescent thalassemics. Ma'am's special interests are disorders of vitamin D and calcium metabolism, growth and thyroid disorders, endocrine issues in thalassemia, pediatric HIV, and HIV-exposed infants. We welcome you, ma'am, to today's program.
Thank you.
And we have Dr. Vikas Jain. He's additional professor, Department of Pediatric Gastroenterology, PGICH, and his special interests are hepatitis B, autoimmune liver diseases, and abdominal tuberculosis. And he's our go-to person when we have hepatitis B, C, and all other liver issues when we deal with our patients. We welcome you, Dr. Vikas.
Thank you, Dr. Nita.
And for the cases, so the cases are being presented by, again, a group of young Turks we have in the departments, and they have managed these children whom we are going to discuss today. So we'll hear from them regarding what were the difficulties and what were the challenges we faced while managing these children. So I'll introduce Dr. Archit. Dr. Archit is assistant professor in our department. Dr. Anuj Singh, he is again AP in our department. Dr. Silky Jain and Dr. Hari Gere. Dr. Silky Jain is assistant professor in our department, and Dr. Hari is currently pursuing his fellowship. So we'll hear from them regarding the cases and what were the difficulties, and we'll hear from the experts as to how we managed them. So over to the cases. So we'll start with case. We've slightly changed the order of cases because there are some other clashing meetings. So we'll start with Dr. Anuj's case now. Over to you, Dr. Anuj.
Thank you, ma'am. So beginning with the first case for today's panel discussion. So we had a 13-year-old boy, case of transfusion-dependent thalassemia, diagnosed at 6 months of age, and he was on regular transfusion support. In the last year, August, he was diagnosed to have hepatitis C positivity, for which he was treated. And his serum ferritin levels, recent value in November was 1500 nanogram per ml. And MRI T2 star revealed moderate liver iron overdose. So kid had a matched sibling donor available, and for which family was arranging funds, and funds were sanctioned in January 2024, and child was waiting for bone marrow transplant at our center. So in March 2024, child presented to us with fever and respiratory distress with hypoxemia, and chest X-ray revealed bronchopneumonia. He had pancytopenia with low retic count. So child was started on supportive care, and viral panel and all workup was done, which was negative. A possibility of parvo infection was also kept, and parvovirus PCR was negative. He was managed as a case of acute respiratory distress syndrome, probably viral etiology, and was given steroids, IV, IG, and antibiotics. His oral chelation medicines were stopped. He recovered from the illness over the next course of 2 weeks. And subsequently, he could be tapered from oxygen, and he was attending schools and was started back on regular transfusion support. And now our main questions for today's discussion are, so on examination also, I would like to add child had low height for age, Tanner stage 2, and he had a hepatomegaly of liver 3 centimeters below right costal margin and spleen palpable below 5 centimeters. And now his lungs are clear and cardiac examination was normal. So our first question for the discussion, I would like to ask Dr. Tulika ma'am. Ma'am, how do we prognosticate kids with thalassemia for bone marrow transplant?
So thank you. That's a really important question because this is important to guide the families about the risk of transplant. So though we would like all children to go for transplant, but it is a risky procedure. So the Lucarelli classification was what was used earlier. What we found was that the majority of patients in India were all Lucarelli class 3, but even within the Lucarelli class 3, there was variations. And so there is a classification which has come out from CMC Vellore, since they have the largest body of work on transplants for thalassemia. And they found that children that were older than 7 years old and who had a large spleen were in the class 3 Lucarelli, they were actually worse prognosis versus children who were slightly younger and did not have splenomegaly and Lucarelli class 3 did better. So that's how we explain to the family about the risk of transplant, because class 3 patients need to be aware of the risk and the mortality and morbidity of EMT.
Thank you, ma'am.
Now moving on to the second question to Dr. Revdi ma'am. So ma'am, we just want to know, like, our adolescents, those who are interested to undergo bone marrow transplant, how to counsel them for match family donor or an unrelated donor or mismatched donor. Like, we do not have the match sibling donor, the ideal scenario which we need in all the cases. So your opinion regarding this scenario?
So thank you, Ms. Shobha Tuli and Neeta for arranging this really important meeting, because there is so much that we can do for awareness and improve standards of care in our country for thalassemia patients. So thank you for the meeting. I just want to add that Tulika had, I think by in error, mentioned splenomegaly. So Vellore high risk is liver over 5 centimeter and age over 7 years. So for those of you who are listening. So for coming to this question, we had a lot of concerns when we are transplanting patients with thalassemia, because their liver is loaded with iron, and the main chemotherapy drug that we use to remove the stem cells in the patient's body was busulfan. And busulfan was highly hepatotoxic. And in patients who already had liver chock-a-block with iron and you give them this hepatotoxic agent, the chances of losing the patient to a particular problem called veno-occlusive disease, now called sinusoidal obstruction syndrome, was high. So now we've moved over to another drug called triosulfan. So with the combination of fludarabine, thiotepa, and triosulfan, in our own series, we have found that this age less than 7 years and age more than 7 years did not really make a difference. So we are able to transplant teenagers. We are able to transplant young adults safely. So the only thing that we say, if anyone has a matched family donor, we have to lay the foundation for them, no matter what their age. We will be able to give them aggressive chelation, prepare them for a transplant, take about 3 to 6 months to get their general condition in good shape. And for matched family donor, using a triosulfan-based protocol, we are able to do any age transplant. So when we are looking for someone counseling, this is the only thing we look at: what is their age and what is their donor status, what is their maximum ferritin and organ function and hepatomegaly. So for matched family donor, really, we are able to offer for even older age group. The only thing we do is change the doses of the conditioning drugs we use. For example, if it is a very small baby, less than 6 months, we use triosulfan at 10 grams. 6 months to 1 year, we use it at 12 grams, and above 1 year, we use it at 14 grams. So if we are using thiotepa in a teenager or young adult, because it is gut toxic, we reduce the thiotepa dose. Instead of 8 milligram per kg, we use it at 5 milligram per kg. With these alterations, we're able to do matched family and matched unrelated donor. The problem is that as long as they are between the ages of 13 and 16, we are able to manage. But once they're above 16, the risks of transplant does go up for unrelated and mismatched donor. So here, we are very hesitant in counseling for the older patients. And financial arrangements is a problem. So there are schemes from the government for matched family donor, but unrelated and mismatched donor, especially haploidentical, very few government and non-government organizations are sponsoring. But with the haploidentical transplant now, we are getting excellent results in a lot of centers. So the success rate is between 85 to 90%. So it depends on whether any family is willing to take that 10 to 15% risk or not.
Thank you, ma'am.
Okay, ma'am. Yeah, so now our third question is for Dr. Vikas, sir. So similar to our case, there are many patients which we see, those who are on regular transfusions, on routine monitoring, they are found to be hepatitis C positivity. So, so my question is like, the patient, when they are hepatitis C positive and we have treated him, now he's HCV RNA negative. So, and we are planning for bone marrow transplant. So how should we manage the case throughout the transplant period?
And during the transplantation, I think right now there is no indication of treatment. Hepatitis C RNA negative. This is in contrast to the hepatitis B, in which we follow the total anti-HBC to start the treatment during the immunosuppressive phase. But in acute, in this condition, if antibody is only positive, RNA is a quite sensitive test. So we should monitor these patients. You can monitor the patient up just for 2 monthly, 3 monthly, directly RNA level you can check. As soon as the RNA level just keep on rising, then immediately start the therapy. But preemptive therapy on the basis of positive antibody in the absence of the HCV RNA is not justified.
Thank you, Dr. Vikas.
So now our fourth question is for Dr. Revati, ma'am. So, ma'am, like we know we need to have low ferritin level, and there should be as minimum as possible iron ore load in the liver and cardiac. So how do we optimize chelation status for bone marrow transplant in such children? And what should be is there any target ferritin or iron ore load parameter values which we should target?
So thanks, especially somebody like the child you had mentioned with hepatitis C, the liver is inflamed and hence the ferritin is likely to be high. But first thing we do a cardiac MRI for any child who's above 8 years of age, and then we'll assess how much is the liver iron and how much is the cardiac iron. And if we feel that the liver iron is high or the cardiac iron is high, we take about 8 weeks time to prepare the patient for the transplant. So this is something called pre-transplant immunosuppression. So we use fludarabine and dexamethasone because this reduces the inflammation in the liver and reduces the immune system of the patient so that they don't reject the new graft. Simultaneously, we use the Baxter balloon pump where they're getting 24 hours IV chelation all through the 6 to 8 weeks. So with this pre-transplant immunosuppression regimen with chemotherapy and with continuous desferal infusion, we are able to reduce the iron. In this day and age, with the triosulfan protocol, we are not doing liver biopsies, we are not doing fibroscans, or we are not targeting a ferritin. If their liver function is okay, there is no hepatomegaly beyond 5 centimeter, we are able to proceed with the transplant.
Ma'am, one small doubt. Also, do you suggest this fludarabine and dexamethasone for matched sibling donor
No,
also?
if this is a child that has come to us, say they've never had chelation in their life and their current ferritin is 7,000, liver size is 5 centimeters. So these are patients that you know for sure are going to reject their graft. So here in this scenario, so we're talking about select scenarios where we know that the rejection risk is high, and there only we use the pre-transplant immunosuppression and chelation. If sometimes it's only a matter of high ferritin, then we do continuous desferal infusion alone for 6 to 8 weeks and then take up. So it all depends on what is the status of the child. So if they've received multiple transfusion without a leukodepletion filter, they've had whole blood transfusion, they've had father to child transfusion. So, you know, these are situations where it's high risk.
Thank you, ma'am. Thank you.
Thank you, ma'am. The next question is to Dr. Anju Singh. Anju Seth, ma'am, so this is an adolescent who is undergoing BMT, and more adolescent kids are now going to getting at least counsel for transplant. So in such a scenario, like in patients who are cancer patients, we routinely counsel for fertility preservation. So how do we counsel regarding fertility in adolescent patients, and are there ways of optimizing their fertility? Anju ma'am?
Thank you. Thank you for having me. I'll answer the second question first. That is, how do we optimize fertility potential in general in children with thalassemia? So, beginning with something obvious would be monitoring the pubertal onset and progression. So, it is every child, regardless of BMT, planned BMT, we would like to monitor their pubertal onset and progression. As long as they're progressing, and it's not only onset, it is also progression, because sometimes they can arrest in between. So we monitor that. And the moment we feel either they are not, they have not started with puberty, or they've started and there's a pubertal arrest, one would like to intervene. And therefore, we would like to catch them early and offer them HRT age appropriate. And of course, at that time, manage the comorbidities as well, because there are many factors that would lead to contribute towards hypogonadism. So if there are other endocrinopathies, one would like to look at them and manage them as well. So this is, and of course, by using the right balance of transfusions and chelation, these children most of them, a lot of them can actually go on to have spontaneous puberty. So that is about, in general, optimizing the fertility potential. A word about the HRT that we use. So in boys, we now have evidence if we use HCG to induce puberty, that is likely to return in a better fertility outcome as compared to using testosterone. So, but though our own experience in using HCG for inducing puberty in children with thalassemia has not been so great. But that is definitely worth a try before we give testosterone. And in girls, a slow buildup of the incremental hormonal therapy so that there's a good uterine growth. So these are the general principles we'll follow for optimizing fertility potential in all children with thalassemia. Coming to BMT, where there is a issue of pre-BMT gonadotoxic drugs being administered. So there are chances of gonadal failure. In such a situation, what can be offered in case of, say, girls would be prior to the chemotherapy, ovarian tissue cryopreservation is an option for prepubertal girls and girls who are in already undergoing puberty. Oocyte cryopreservation by causing controlled ovarian hyperstimulation are the possibilities. For males, if it is the boy has already undergone puberty, then sperm banking is an option. while for a prepubertal boy, maybe testicular cryopreservation. Now, these are exciting possibilities, but the experience in thalassemia per se is not too much with them. We do have some evidence of their use in sickle cell disease, but in thalassemia, the use is still limited, but these are exciting possibilities which can definitely be, will have a more role to play in future. Thank you.
Thank you, ma'am. It's nice to know because more and more children now are coming into that phase, ma'am.
As is their right, absolutely.
Yes, ma'am. Yes.
Ma'am, next question is for Revati, ma'am. Ma'am, like we just discussed the hepatotropic virus infections in thalassemia patients. So for BMT, is any of these like hepatitis B positivity or Hep C positivity or HIV positivity in recipient, is any of these a contraindication for bone marrow transplant? Or
So amazing. I haven't transplanted a HIV positive patient, but it is not a contraindication. Obviously, after a BMT, 3 months, their immune system will be really low. And at that time, we have to take adequate precautions and continue their antivirals. We have done several patients with hepatitis C, safely transplanted them because we now have this combination antiviral therapy for hepatitis C. So Velasof for all the genotypes we can use, and it doesn't have drug interactions with our BMT medications. So it's a safe drug to use. Hepatitis B, we again can use entecavir and proceed. We prefer not to have very high viral load. So the first thing is to make sure viral load has come down with therapy and we've reduced their iron and the liver functions are okay before we proceed. And avoid busulfan in these patients and use preferentially triosulfan, which is non-hepatotoxic.
thank you, ma'am. So, ma'am, next question is for Dr. Tulika, ma'am. Ma'am, post-transplant, regarding the chelation, when should we start the chelation in a patient post HSCT? And also, do we need to follow them up with the ferritin or MRI T2 star for iron overload?
Okay, so first of all, thanks to Revati, I misspoke. I'm trying to do two things. So yes, it's hepatomegaly, not splenomegaly for the risk stratification. Coming back to the question on chelation, post-transplant, most of my patients are iron overloaded, so we do need to start chelation. We usually start around 1 year post-transplant, and we continue the iron chelation until the ferritin gets to be around 400 or so. We have not been monitoring these patients by MRI. We usually follow the ferritin. But I think if you had somebody who had severe cardiac or something, it might be a little bit different. Most of the time, we have already evaluated patients pre-transplant, and if they have very severe iron overload, we will do dual chelation and we'll try to correct that before we take them to transplant. In those cases, you may want to do an MRI later on, but majority of patients, we just follow the ferritin, and the duration would vary from patient to patient. Sometimes, up to a year of chelation, sometimes less, because they're now not receiving transfusions, but we continue until the ferritin is around 400 or definitely less than 500.
Thank you, ma'am. So our next question is on one of the other major organ other than liver is pulmonary, and it is regarding similar to our case. So Dr. Revati, ma'am, our main question here is there is also iron overload in the pulmonary parenchymal tissue, and does this impact BMT outcomes also when the patient, similar to our case, if they have a severe pulmonary event just 2 to 3 months prior to HSCT, how do we manage conditioning differently in these cases, and what complications we will be expecting?
So your child seems to have had a very bad viral event and has recovered. And we transplant so many leukemic patients, primary immune deficiency patients who are riddled with CMV pneumonitis and BCG pneumonitis. So it's definitely not a contraindication. Basically, this child, we would do a HRCT test if they're old enough to do a lung function and a 6-minute walk test. If all of these are fine and the echo is fine, we can proceed with the transplant. So a lung is not a major contraindication because we have seen patients during chemotherapy, they've had aspergillus pneumonia, we've taken up. So that's not a contraindication really. So this child, I wouldn't, if the lung functions are okay and CT chest is okay, we do nothing differently except avoid again. If the lung or the liver is hit, then use trio over busulfan. And also to add to Dr. Anju Seth's question on fertility, it has a huge impact. So what we do today to these children has an impact on their future. The conditioning drugs that we use has an impact on their fertility. So if they are very small, much younger children, the fertility with busulfan is preserved. But the older children do have primary gonadal failure. With the triosulfan-based protocol, all of our patients have gone through menarche, attained menarche, gone through puberty. And in fact, what we are seeing now is more precocious puberty, early menarche. So these are the sort of things that we are seeing with the triosulfan protocol. And some of our patients have also managed to deliver a baby. So I think with times changing, we should think of their fertility issues when we are considering a patient for transplant.
Thank you. So moving on to the next question for Tulika ma'am. Ma'am, many of our older kids and adolescents who are on regular transfusion, they have moderate to massive splenomegaly. So does this impact outcome during transplant?
So yes, it does. And earlier when we had started transplants at our center, often these would be the children who would have rejection. So if you have a patient, it's a good idea to prepare these patients. Sometimes you can do a protocol where we give hydroxyurea and hypertransfusion. And many times these patients, then the spleen may regress somewhat. I saw in the chat box, some people had asked about irradiation and splenectomy. I'm not sure if that's something that we practice for thalassemia. In myelofibrosis patients, there is data to suggest that patients with very big spleens may benefit from splenic irradiation and splenectomy. But in children with thalassemia, we try to avoid splenectomy because we know that there'll be other complications that can be there. On an individual case to case, there might be some patient who would benefit from a splenectomy, but on the whole, we try to avoid it. And as I said, there is a risk of rejection in these patients, so they're a little bit difficult.
Thank you, ma'am.
Thank you, ma'am. And finally, ma'am, to Revati ma'am, a question for pediatricians who have joined in today. One is like, what will be the ideal age of BMT? I think again, partially answered already. And in your center, when you do not get an HLA match in the family, how frequently do you do a mud search, or do you, if it's not coming up, there's no match in the first go, do you proceed for alternate donor transplant?
So thank you, Neeta. I think this is a very important question. If I have a sad day and I have to counsel a new family that the child is being diagnosed with thalassemia major, I definitely do two things. Talk to them about what they can do for themselves and their extended family to prevent another birth in that family. So that's number one. And we start talking to them about transplant early. Because previously what we used to see when they were 12 and they could no longer come under the pediatrician that they trusted, then only they think about transplant referral. And more we have data to say the younger they are during transplants, the outcomes better. So as pediatricians, we always have this feeling that maybe they are too poor, they won't understand about the transplant, or they don't have a sibling, so there's no donor. So we now have different ways of transplanting children. So if they have a matched sibling donor, that's great. If they don't, then we do an international search. There are about 25 to 30 million people registered worldwide. We can put this child's HLA typing online, and then there is another 30% chance that a child will get a fully matched donor from the unrelated registry. Then we are left about 40–50% of the children who don't have matched donor at all. So for here, we can use a half-matched parent or a sibling as a donor, which is called haploidentical stem cell transplantation. And the success rates for haplotransplants have dramatically increased over the last 3 years. There are two ways to do haplotransplant, either to clean the stem cells using a technique called TCR alpha beta depletion, or to use a drug called cyclophosphamide after we give the stem cells, which is called PTCY protocol. And each center can decide what they are comfortable with and offer to their family. So the one thing is, do a transplant referral early so that the families can decide what they wish to do.
Thank you, ma'am. I think we'll take two questions related to transplant in this case only. So one is regarding after transplant. So Dr. Himanshu Saraswat asks, after transplant, what is the average year of life added and course of stay after transplant in terms of infection and rejection?
Okay, beautiful question. So we have changed the immune system and the blood forming system. So, you know, from your newborn baby, it takes about 3 months for the newborn baby's immune system to get better, which is why we do all the primary vaccinations and wait for about 3 months before we expose the baby to multiple family members and to the outside world. So our transplant patients are exactly like that. It takes about 3 months for the immune system to get better. The bone marrow transplant patients are different to solid organ because they need immunosuppression only for an average of about 1 year. The solid organ transplant patients are on immunosuppression lifelong. So after 1 year, we take them off their immunosuppression and then give all their primary vaccinations. So this is where a pediatrician should be aware that we start from scratch with the DPT, polio, everything, and then they are good to be as any other patient. So if we are not using radiotherapy and they are not on continued immunosuppression, for example, if they have graft versus host disease, then they're not very immunocompromised. Obviously, anyone with a previous history of chemotherapy, you would have a little bit more concern if they have any bad infection. So if you need to give the antibiotics and support them, that would be a good thing to do and have a more targeted approach to these patients. But most of them lead a normal life. So the transplant is mainly done so that they can lead a normal life, and we have to get the ferritin down, as Dr. Tulika said. We can use phlebotomy, we can use chelation, but we have to bring their ferritin down to less than 300, and this can take 2 to 3 years as well.
Thank you, ma'am. And a quick question on pregnancy. Like there are, so Anju ma'am, there is a question regarding any special precautions during pregnancy in a thalassemia female?
I am not the right person to answer. I deal with children, I deal with adolescents till 18. So I will defer from asking.
I can help you with this,
maybe,
Neeta, because
yes, Revati, I think you have a lot of experience.
Right.
I might have something to say on the fertility preservation issue, but I will defer to you, Revati, here.
Because in our Thalassemia Society, we have patients ranging from 3 years and our oldest one is 46 years old, and several pregnancies. So if they've recently been married and we do the pregnancy counseling, so we take them off the chelation, keep them on folic acid, wait for 3 months. If there is no pregnancy, send them to the fertility expert to see if, because they can't be off chelation for a very long time. And once they're pregnant, they can't have, there is no safe chelation in pregnancy. And fortunately, the fetus is a good chelator, will take out as much iron as possible during pregnancy. We keep their hemoglobin above 9 grams so that they don't have any cardiac dysfunction, and follow them up with calcium-rich diet and calcium replacement. In the 3rd trimester, we watch for thrombosis risk. So perinatal period, if we feel there's obesity or post-splenectomy, then we give them low molecular weight heparin.
Thank you, ma'am. I think we'll proceed to the next case. So the next case will be discussed by Dr. Archit.
Good evening to all senior teachers. So shifting gears and discussing other complicated issue and at times difficult. So a 15-year-old child was referred to us from Faridabad. So the referral sheet mentioned that the transfusion frequency was 1 PRBC every 3 weeks with a pre-transfusion hemoglobin around 8.5 to 9. However, a recent onset increase in transfusion frequency was observed, leading to about 3 frequencies in a month. On asking about any complaint specific, there was no history of recent infections or any incidence of hemolytic reactions leading to urine discoloration on jaundice. On clinical examination, the height was less than 3rd centile, no development of secondary sexual characters, a huge spleen. Fortunately, the child was not in congestive heart failure. So the current evaluation, the Hg hemoglobin, when seen in OPD, he was pale, hemoglobin was 5.6. No other features of hypersplenism as such. The TLC and platelets were within normal limits. Corrected retic around 3%. As a part of workup, DCT testing was done and alloantibody screening was sent. So both came out to be positive. And on the typing and discussion with the Department of Transfusion Medicine, they had identified a type of antibody against the rhesus antigen, which was the anti-CW antibody. So now we have a condition wherein there is recent increase in transfusion frequency, possible component of alloimmunity with some component of autoimmunity. So I want to ask Tulika ma'am, like when you see a child for the first time, when he has been referred to you for a consultation, so what do you think in your mind when you want to say the child has been adequately transfused or not? Tulika ma'am, are you able to hear me?
Oh, okay. Sorry, I couldn't unmute. So the adequate transfusion, we have to look at the hemoglobin, but the other things that we're looking at are, many other parameters like, sorry, something's happening here. So, so the question you're asking here is on how do we assess transfusion adequacy. So for that, we look at hemoglobin growth, facial features, whether there's hepatosplenomegaly, sexual development, and extramedullary hematopoiesis. That's how we do that. But in this patient, when you have a sudden increase in frequency, there's basically 2 things that we are thinking out. One is there alloimmunization? And second, is there hypersplenism? So those are the 2 things I would think about in a patient like this. But in your case, you've been able to demonstrate that there is allo and auto immunization. And actually, even in cases of alloimmunization, the data suggests that in about 84% of these patients that we label as alloimmunized, they may also have autoantibodies.
Thank you, ma'am. That was nice. So now I want to ask, there is a recent increase in transfusion frequency. So what are the other possible reasons for such an increase in frequency, and what investigations do we usually do at the first visit? Because again, the patient will be post-transfusion. Possibly some component of severe anemia is present or not. Parents are anxious because most of the time it's a chronic disease. And at times they're aware and people talk, like all the patients have a good networking. So how do you allay the fears and what do you work up them from? Revati ma'am, please.
I like your part which says they all talk to each other. That is so correct. So what we do generally, there aren't any good guidelines for this. So we've given the transfusion, they're having shivering, they have high colored urine. Today hemoglobin was 7, tomorrow it is actually 5. So this is something that is scary for the parents. And when they've developed antibodies, it can be either it can just result in a slow increase in the number of transfusion, or it can be dramatic. Whatever the reason, the blood bank has identified that the antibodies are against this antigen. So we try to cross match 10, 20 units to see what is compatible. So we may have we may have a compatible unit. So wait and cross match and give a compatible unit. We start them on steroids, 1 milligram per kg of prednisolone to reduce the antibodies. Sometimes if it's really dramatic, we've used weekly rituximab at 375 milligrams per meter square for 4 doses. And this helps. In some of the patients, especially we saw this during COVID times because they had transfusions closer to home. They couldn't travel. So a lot of children developed antibodies. And sadly, 3 of them, we'd had to do a splenectomy because their transfusion requirements were so high and they developed hypersplenism. So it is an issue. So filtered blood, which is cross-matched and given as compatible unit is the best way forward. And I think with the government working towards better transfusion standards, we should be seeing less of this.
Thank you, ma'am. And that's again highlights the very important role of a transfusion medicine professional in our team. It is a stark reminder that hematology is always a team game.
So ma'am, another question for Anju ma'am. So this is again a child with short stature. So most of the adolescents we see who have been transfused in primary health centers or district hospitals with very few access to chelation and good transfusion are usually have a severe growth failure by the time they are sent. So how can we prevent this in thalassemia? And now this boy is 15 years old. So can we still work on improving his height in this patient?
Yes, thank you. And as you rightly said, a very common presentation to endocrinologists as far as thalassemics are concerned is an adolescent coming to us with short stature and delayed puberty, the combo. And yes, the prevention actually goes way back. So if we look at the etiology of short stature in these children, various factors contribute, some being more important than others at various stages. So in a child with thalassemia who is under 5 years of age, the main factors that will contribute towards short stature would be anemia and thereby leading to hypoxia and malnutrition. So what is important here is regular transfusion so that anemia is taken care of. As the child gets older, iron overload and its related complications start coming up. And therefore, next step would be timely and adequate chelation. Third thing would be, as the child gets older in the later childhood and coming towards adolescence, growth monitoring, of course, that should begin right from the beginning, from the time the child is registered with you, maintaining a growth chart. Pick up growth faltering rather than short stature and investigate at that point. Don't wait for the child to become short. And finally, once the child is, say, 10 years or so, you start with a routine endocrine screening, and which also includes a comorbidity screening, because all these factors, it is GH-IGF-1 axis, it is hypothyroidism, and as the child comes into adolescence, it's the hypogonadism. All of them have a cumulative effect, not to mention the effect of other comorbidity. It could be, say, hepatitis B or C or HIV. So it's a combination of all these that is causing short stature, and one needs to prevent it, focusing on various aspects at different points of time. So, and if a child is well transfused, well chelated, we find them having a good height. At our own center, we have seen the change. Dr. Jagdish had shown the figures, how the outcome of children at our own center changed. And about this child at 15 years of age, it is very likely that this child has some endocrinopathies. So definitely hypogonadism is obvious here. So it is possible to improve height. It would depend how much height potential remains, depends on the bone age of the child. So if this child is pre-pubertal right now, it is likely his bone age is less than, say, 12 years for a girl or 13 years for a boy. So looking at the bone age, it is possible for the height to improve if there is associated hypothyroidism or growth hormone deficiency, correcting those, and then hormonal therapy, the sex steroid therapy is going to help improve the height somewhat.
Thank you,
That's
ma'am.
it.
So all patterns of endocrine involvement can occur either chronologically or they can happen in a myriad way depending upon how the child has previously behaved and has been previously treated. And as per ma'am, mid-parental height can be achieved in children if they are well transfused and adequately chelated.
Monitoring is important.
So monitoring in the sense is height, like growth velocity.
Yes, growth monitoring,
height,
and
weight.
after 10 years, endocrine screening, a comprehensive screening, so that you are looking at every aspect. And just one more thing I would add there, you've written height less than third centile. It will be great if we actually measure the exact Z scores. We now have apps. So that will actually tell you, for example, if this child was at a height Z score of something as low as -4 or -5, I would be very keen to look at the growth hormone axis in this child, vis-a-vis if it was much less.
Ma'am, a low Z score is responsible for a secondary cause of short stature. Like
Yeah,
if
yeah. If it is, say, something like, say, -4, -5, the child is so short, one would actually think that in addition to hypogonadism alone, probably there is a involvement of the GH-IGF-1 axis also, and of course thyroid also. So more is shorter is the stature, more are the chances that there are multiple endocrinopathies present. Remember, the risk factors are common, right? So if a child is poorly chelated, he is likely to have more endocrinopathies. So occurrence of multiple endocrinopathies cannot be ruled out.
Thank you, ma'am. That was really nice. Like there are many adult physicians also in the webinar who at times find short stature as a difficult component to deal with. So now going to Satyam Arora, sir. Like when am I audible to you, sir?
Yes.
Okay. So, sir, when we spoke on the phone about this child, so you knew that there was an increase in frequency, and you told us that the child is recently transfused. So, what all was going in your mind when I told you that there is a recent increase in frequency, and what all comes to your mind from a transfusion perspective, and what a clinician should know about it? Because at times DAT and IIT are difficult concepts to remember in OPD. We can learn them, but when it comes to clinic, at times we falter. So what comes into your mind and what should a clinician remember?
Yes, thank you. Thank you for this question. Actually, it was a very interesting case, and whenever we get a consultation from for a thalassemia suspected aluminization, we really want to know what is the last transfusion history. We cross-verify the blood groups that the patient has received, the whatever the blood group is historically known to the patient, and what is the sample that is received to us. We also want to know whether if during the time of first transfusion, whether the patient was typed for RH and KL blood groups, so that since RH is one of the most common cause of aluminization in thalassemia in our country, and if we know the pattern of original phenotype of this patient, we can assess what kind of antibodies can this patient make. As far as this case was concerned, it was very interestingly, the DCT was 2+, and it has a pan reactivity. If you can see on the top of the, the cards, the left one is talking about the auto and 3-cell panel, which was positive, and then even the 11-cell panel, which was a pan reactive. So it was showing that there is a component of auto antibody in this case. Now, very interestingly, if you see, there is a variation of the reaction in the well. So cell 1, both in 3-cell panel and 11-cell panel, has a larger reaction, which is close to 4+ as compared to rest of the cells. So this gave us a clue that whenever there is variation of the reactions in a gel card, it signifies that there is an allo plus an auto, which may be present in this case. And that is what we did. We did a series of allo adsorption to remove all the auto antibody which was there in the serum. And we found out that the antibody was against the CW antigen. Very interestingly, this CW antigen is a low frequency antigen. So it is the prevalence of this antigen in Indian population is less than 2%. So we know that out of 100 bags, we just have 1 or 2 bags which may be CW positive. Sadly, even in our country, we don't have an anti-sera for CW, and this patient was repeatedly transfused. So we really can't phenotype this patient to establish that the patient was CW negative. But anyhow, considering that CW is a low frequency antigen, we presume that this patient would have been CW negative. And in a follow-up, we gave 2 units since this case was reported to us for transfusion, and those were compatible transfusion from this absorbed serum, and the patient is doing fine and has seen a rise of hemoglobin since then. So our main focus is to do DCT followed by a 3-cell panel. We want to rule out whether there is an auto or an allo. And if it's pure allo, it's something that we can help you with, since we can identify the antigen, provide you an antigen negative blood. But if it is an allo plus an auto, that becomes a challenging situation, and I'm happy that we were able to solve the allo part of this antibody with us.
Thank you, Satyam sir. Going to the next part. Tulika ma'am, an allo antibody has been fortunately identified with these patients. So in the initial part of therapy, do we give steroids along with matched PRBCs, or only matched PRBCs could do in the short term?
So, as Dr. Arora has said, uh, the most important thing that often is forgotten is when we start transfusion, you have to have an extended fusions. You can't do the routine extended phenotype, then you need to do it by molecular methods. Now, if it is a pure allo antibody, classically the textbooks have said you just need to have a good transfusion medicine person like Dr. Satyam, and you give antibody negative blood. But many times it is seen that there can be a component of autoantibodies as well. In some articles on in thalassemia patients, it's been reported even up to 80%. Though I would say in my hospital, we don't see such high allo and autoantibodies. Sometimes when we've suspected, we do the Z-sorption, and our transfusion medicine people can tell us if we have auto and allo. In case you're not sure, you can give steroids along with the red cell matching. The red cell matching by the transfusion medicine person is the most important part. And if you're doubtful that there might be an autoantibody, you can give steroids along with that. But I would recommend that not to give steroids for a long time unless you're sure that there is an autoantibody. Even when you have an autoantibody, usually after 2-3 months, if things start getting better, we start tapering down the steroids, because we must remember that in thalassemia patients, giving high doses of steroids for a long time is not a good idea. You will get infections. But the most important is your blood bank transfusion medicine support. And as I said, steroids can be given. And many times, even though, as I said, classically, it's not recommended, but we do often see some response. Even in patients where we haven't been able to demonstrate autoantibody, maybe it's just something that we feel. But if you're using steroids, use it for only like 2-3 months and then taper it off.
Thank you.
Thank you, ma'am. So this coming back to the DCT question again, Dr. Satyam. So why would a person with thalassemia have an autoantibody? Because the autoantibody, we typically have reasons for it, right? We have exposure to infections, rheumatological cause, etc. So why do you think thalassemia patients are more prone for autoantibody formation?
Yeah, so I think this was briefly mentioned by Dr. Tulika as well, that auto antibody prevalence is reported to be as high as up to 30% in thalassemia patients. The study which we published from PGI Chandigarh of more than 300 patients, and even recent study from Egypt show that there is an incidence of nearly 20% of auto antibody in thalassemia patients who are receiving multiple transfusions. So there are multiple reasons which have actually hypothesized why there is a incidence of higher autoantibodies. One of the reason is the altered immune system that the patient gets a hit with repeated transfusion. Another is because of excess of alpha change that the patient keeps making. There is a alteration of the red cells which are there of the patient, in which stimulates the immune system. One hypothesis is if the patient is post splenectomy. So splenectomy is one of the high risk factors for developing an autoantibody, since there is less filtration of the antigens that are received by the patient through the transfused cells. And it has also been seen that providing leukoreduced blood can reduce the incidence of auto and alloantibody development in this patient. So there are multiple reasons. There are few mutations as well. So there are some mutation on beta chain locus around 11th chromosome, which makes few patients more susceptible to develop autoantibodies. And yes, this autoantibody is a very difficult scenario for us from transfusion medicine side as well as from the clinician side to manage and support patients.
Thank you, sir.
Thank you. And Revati ma'am, so we discussed regarding red cells matching and steroid also, but what are the other strategies? And I want to club the next question also for you because ma'am has a meeting and she wishes to leave after this. So 3 questions. One is, what are the other strategies for management? Second is, there are new agents, like now there is ruxolitinib, there is thalidomide, all these are coming in. And a third thing which we discussed today morning was, if it's a very severely alloimmunized child, then we are still definitely not able to manage. Like even Chandra sir said that they can keep a lower threshold, as in lower hemoglobin target, if you are not able to get. But then that will also be bad in the long run. So will you consider transplant in such patients?
Yes, so thank you for this. It is a challenge, and during transplant also they will need a lot of units. So if they are floridly alloimmunized, the amount more than the red cells, the number of units of platelets they require when they have mucositis, they will bleed a lot. So it is good to bring the antibody level way down. So other than rituximab, we can use IVIG, we can use bortezomib, and we can use plasma exchange to bring all these antibodies down. So these all together, we try to bring their antibody level down before we take up for transplant, not take them in with active autoimmune hemolytic anemia, because it won't be easy for the child or the transplant team. So whatever is needed to, it's all of these are like a burning forest fire. So it's better to put it out before we start the transplant program. But sometimes it is an indication, if they are heavily alloimmunized, it is an indication for transplant, and we get the antigen panel matched blood product before we start.
And ruxolitinib and thalidomide, ma'am?
I don't have much experience, but we've used ruxolitinib for those with a very big spleen to reduce the size of the spleen before transplant. I don't have any experience with thalidomide in this group here.
And there's a question on MMF and other immunosuppressants.
So here we need all these things to work fast. MMF is good when we are thinking of chronic strategies. So if you want to get the antibody level down fast, it's not a drug that I would recommend.
Thank you. Well, thank you, ma'am, because you have to leave. And thank you for the wonderful discussion. We hope to have you again soon. Thank you. So we proceed with the next question.
So question to Satyam sir again. What are the thalassemia child first time new diagnosis is coming to you? So what is the optimal strategy to prevent alloimmunization at diagnosis? And when they say about extended RBC matching, do you feel it is the cost benefit ratio is feasible? Because for everything you have to give explanation, whether it is feasible, whether it will help in the long run, what is the cost benefit ratio? So what do you feel about this?
So I feel whenever you register a new diagnosed case of thalassemia, that patient should undergo a complete RH and KEL matching at least. So that is just the basic matching, I think, which is available with most of the blood centers. Another important thing that I want to just put on record is one of the most important thing to develop an alloimmunization is the antigenic difference between the donor and the recipient. So we have one of the best systems in US. Still, they have a very high incidence of alloimmunization in their sickle and thalassemics as compared to what we have in our part of the world. One of the reasons are that the patient belongs to some other race and the donor which donate blood for them are from different antigenic profile. This is very different from from people who are like, for our center, our experience have been very different, since our patient also belongs to the belt of Western UP and our donors are also from the same belt. So this is, there is most of the antigens must be similar, though we have started antigenic phenotyping of our patients and our donors. So This is one thing which is very important. Another thing is, for any thalassemia patient, as a standard of care, should receive ABO, RH and KEL matched blood. That will cover more than 80% of possible antibodies that the patient may make in coming future. Talking about really an extended panel to be matched, to be as high as 10 or 12 antigens. So yes, there are practical and cost implications around it. It is very difficult to sustain doing phenotyping of so many donors and making a registry for these different phenotype matched donors for these patients. So as far as I think the Indian context is concerned, at least RH and KEL should be done, and that will help most of our patients.
That's thank you, sir. That's a very important thing. Like basic blood grouping should be very helpful to prevent 80% alloimmunizations. Thank you. Tulika ma'am, when you were examiner, you asked me, ki, will you do splenectomy for this patient? And I said yes. So then you told me no, it increases the rate of alloimmunization. So then when we are in a difficult situation, ki it's a refractory alloimmunization. Fortunately, we are not able to do anything. The child is in a state of borderline gallop failure. We are also anxious. So can splenectomy help as a stopgap measure, as it does in ITP maybe?
Yeah, so this kind of works both ways. If you have a patient who's splenectomized, there is going to be a higher risk of alloimmunization. So nowadays, before taking the decision to splenectomize patients, we have to really weigh that. Now, on the other hand, once you have a patient who has alloimmunization and the patient, you're not able to respond many times, once they develop alloantibodies, they keep developing new antibodies. You are in a different situation, and sometimes in a case to case, you may want to do a splenectomy, which will reduce the red cell destruction, and it may help in an individual case. But again, it's not something that we always use. Something that we've tried in a few patients, because I've actually never had to do alloimmunization patient splenectomy for the alloimmunization management. But one thing that I have tried is that we've used hydroxyurea. And often what that does is it reduces the size of the spleen, and it kind of, helps a little bit. And of course, then with the good blood bank support, we are able to pull these patients through. We haven't used luspatercept or anything in that sense, but hydroxyurea also reduces the spleen size many times. So even though it won't help with the transfusion need, like it would in non-transfusion dependent thalassemias, because this is a transfusion dependent thalassemia. But in a few cases, I've used it, and it's helped me get through it. But as I said, in a rare case where you have refractory alloimmunization, they've even had some case reports where they've done a partial splenectomy or they've done a splenectomy. So not in all patients, but in some patients, when you're in between a rock and a hard place, it could help. So yes, you're right.
Thank you, ma'am. Thank you so much. Anju ma'am, delayed puberty, like you discussed with us, like absence of secondary sexual characters with a height possibly less than third centile with a maybe exact Z score. This candidate is actually a good candidate to be referred to an endocrinologist for hormone replacement therapy for puberty induction. So just to make sense to a hematologist, not going into too many details, how do you do it? Just in a basic way, like.
So if we have this 15-year-old boy and who has come to us with short stature and delayed puberty, you need to do a complete endocrine evaluation. As I had mentioned earlier, it is not only looking at hypogonadism, it is also looking at other endocrine involvement. It begins with doing a bone age assessment, and it adds, one would like to at least do a thyroid. And in addition, if the child is extremely short and the bone age is really, really retarded, then I would also assess the growth hormone. Because if these are all important contributors towards stature, presuming these are all taken care of, certainly 15 is the age when we would start hormone replacement. Ideally, we are following these children, tracking their puberty, and if the signs of puberty have not started in the boy by 14 years of age or in a girl by 13 years of age, one would not wait more. One would start the incremental hormonal therapy. And in boys, what we would do now is always try giving HCG first, because HCG is actually going to, has a LH-like action. Therefore, it will act on the testes and cause increase in testicular size, which in turn we hope is going to produce testosterone. So HCG has worked well in other situations where there is a delay in puberty. However, the experience, as I mentioned earlier, in children with thalassemia has not been so great. One possibility is that maybe there is already a existing gonadal damage also, and therefore the testes are not responding so well. Though most of the type of hypogonadism these children have is hypogonadotrophic hypogonadism. In any case, we would always give a trial of 6 to 12 months before giving anything else. If they respond by increase in testes and they enter puberty, wonderful. If they don't, then we would give a incremental testosterone support to these children, mimicking a normal puberty till we reach an adult replacement dose. I hope that answers your question.
More than enough it answers. Thank you.
Thank you, ma'am. Thank you for that wonderful discussion. Now we proceed with the third case. I think we are running a little late, so we'll quickly do the next two cases. Dr. Hari will be presenting the third case. Over to you, Dr. Hari.
Thank you, ma'am. I am going to present the next case. She is 18-year-old female. She presented to us at 15 years of age. She was second born out of non-consanguineous marriage. First time pallor was noticed at 8 years of age. And then from 8 years of age till 15 years of age, she was managed as a case of non-transfusion dependent thalassemia at the other center. But she had an issue that she didn't achieve menarche. And then with this complaint, she presented to our center. And on examination, she had pallor, mild icterus was there. She had short stature. Pubic hair and thelarche was present, but menarche she hadn't attained. And for abdominal examination, spleen was massively enlarged. And then we proceeded with the SPLC at our center, and hemoglobin SVF was 41%, SVA was 45%, and she was counseled and she was put on regular transfusion regimen as there was poor growth and delayed puberty. And after 6 months of regular transfusion, menarche was achieved. We set a target of pre-transfusion target of 9.5, but despite of every 2-unit transfusion in every 15 days, still pre-transfusion values were at 8.5 to 9 gram. We couldn't achieve the target of 9.5. Let's discuss about the hepatitis course of this same patient. At presentation, child was mildly icteric, and on evaluation, IgM HCV was positive at the presentation. This was at 2022 January, and HBS AG was negative. Then we did the viral load of HCV, which was not detected. So patient was put up on regular follow-up, and then she had no issues back then. And again in December 2023, she presented with the vomiting and icterus. On viral evaluation, HBS AG was reactive, HBS AG was positive, and anti-HCV IgM was negative. Anti-HCV was negative. Hepatitis A IgM was negative. Once HBS AG was positive, we did the further serology, and HBE AG was positive. Anti-HBE was negative, and anti-HBC was positive. So, and viral load was done, and SBB DNA was 8.6 to the into 10 power 6. So, and we did the serial monitoring of LFT, and initially she had bilirubin of 20.7, which was on gradually falling trend, and current latest of April was 4.3. There is a gradual reduction in the LFT, and we discussed with the pediatric gastro team, and we kept the patient on regular follow-up. We didn't have to start any antivirals. So coming to the questions, since this patient till 8 years of age, she had no diagnosis. After that, she was told she was diagnosed as non-transfusion dependent, and now she is transfusion dependent. So my question to Tulika said, ma'am, how do we label patient as transfusion dependent or non-transfusion dependent, and is age of starting transfusion really significant in such scenarios?
Okay, so thank you. That's a really good question. So earlier we used to use terms like thalassemia intermediate and thalassemia major. And in that, we would say if somebody is transfused, gets transfusion less than 2 years, they're thalassemia intermediate. But that was not a good definition. And so now the terminology of transfusion dependent and non-transfusion dependent is there. Usually patients who are transfusion dependent, they will have more severe anemia. They will present earlier, less than 2 years of age. They don't have jaundice, and they have, all the classic features that you would see in thalassemia major. The non-transfusion dependent patients, they present at a later age, usually after the age of 2 years. Many times they can actually present even in the first or second decade of life. Often there is icterus, there's splenomegaly may be there. The anemia can be variable. The anemia in these patients can be there only maybe when they get sick or during the growth spurt period. And so that's why the non-transfusion dependent thalassemia is the new terminology. And some of these non-transfusion dependent patients can become transfusion dependent. It's a terminology called NEO, neo transfusion dependent. Because they have converted to that. So that may be either because of growth, or maybe sometimes we may intentionally convert them into transfusion dependent to ensure height progression, because if the hemoglobin is low, they will not grow. Or if there are things like extramedullary hematopoiesis, where if you give them transfusions, the extramedullary hematopoiesis will regress. Even if there's very big spleen, that can sometimes regress. And some of these patients can then become transfusion dependent, either because they've got treatment or because that problem is gone. And then there are patients who are intermittent transfusion dependent. So there's a lot of new terminology that has come, but it actually describes the status of the patient in a better way than the old terminology did.
Thank you, ma'am. Now, my second question is to Anju, ma'am. Since we see so many non-transfusion thalassemia cases, non-transfusion dependent thalassemia cases, and most of the cases we see there is poor growth and pivotal delay. I would like to ask ma'am that how do you advise such patients?
Yes, thank you. Even though literature suggests that patients with non-transfusion dependent thalassemia have lower rate of endocrine complications, including short stature and delayed puberty. We can see some of these patients. In fact, a publication from our own center had about 10 or 11.5% short stature, pathological short stature in NTDT. So the main contributing factors here could be primarily anemia and iron overload, like with the thalassemia. Of course, here the iron overload is because of maybe ineffective erythropoiesis, hemolysis, and increased gut absorption. So these two are the reasons from the thalassemia point of view. But remember, like any other child, they're also vulnerable to other diseases. So there could be a familial short stature, there could be a thyroid, there could be calorie depletion, there could be other comorbidities. So in such a case, we would evaluate them like any other short child, which means basically doing a good systemic screen, looking at systemic involvement, keeping in mind that they do have some tendency for the thalassemia related issues, that namely iron overload. We will evaluate them in exactly the same way and manage similarly.
Thank you, ma'am. So my next question is to Satyam sir. Since non-transfusion thalassemia, non-transfusion dependent thalassemia cases poses slightly challenge again than the transfusion dependent cases, kindly present us a transfusion medicine perspective of it. How do you look such cases?
Yes, thank you. So there are two things which are very important, that these NTDTs, or previously called as thalassemia intermediates, they are more prone to develop alloantibodies as compared to the thalassemia major ones. And that is the reason it is recommended that we phenotype even anti-DTs when they registered with the clinical site. So if in future they may, if they require a transfusion, we have the pre-transfusion RH and Kel phenotype with them. Another thing is that when we are suspecting that these patients will, are more prone to develop alloantibodies and also multiple alloantibodies. So we try to provide from the beginning the RH and Kel matched blood, the phenotype matched blood, the leuko-reduced blood to reduce the incidence. And anti-DT, when they become adult and they have a higher prevalence of developing these antibodies if they conceive being a female patient or if they undergo a splenectomy. So those are the risk factors that put them to develop more alloantibodies. So our concern is that we know the phenotype and we try to provide as much as phenotype matched blood to them.
Thank you, sir. My next question is to Tulika ma'am. In these newly transfusion dependent cases, which we called as neo TDT, and those with transfusion dependent cases, we set a same target, which is 9.5. And then it is so difficult to achieve 9.5 target in neo TDT cases. So what parameters we rely mainly upon? Would it be growth and puberty or anything?
So yes, so we actually do look at growth because that is the reason most of the time that we are putting them on a transfusion regimen. And many times what I've done for the non-transfusion dependent thalassemias is during the growth spurt, we monitor the growth, and in that we're looking at the growth velocity, and that is something that the families can easily monitor. And once we've achieved the height that we are happy with, we can actually go back to allowing them to have a lower hemoglobin. So you're absolutely right. It is not necessary in such patients to have the target that we have for the transfusion dependent thalassemia patients.
My next question is to Satyam sir. We see often there are transfusion acquired hepatitis B and C. So how do we prevent such cases? And once when we find some patient who is positive, then how do we go back and see which donor which donor had the hepatitis, and how do we screen them? How do we go back to the donor pool and evaluate them?
Yes, so this actually is our major concern. So, the first concern for any blood center is to provide safest possible blood to their patient. And what has been seen with the lot of thalassemia patients, and during this COVID time, there are a lot of patients received blood to blood centers which were closer to them, and it was not sure that what type of testing was done. Very recently, rapid testing has been stopped by the government to be done on, especially on platelet donors and for blood donors. So we still have a lot of, district level blood banks which only do a rapid testing and which will have a lesser sensitivity to pick up these, infections in our donor. The another thing is to provide safest unit of blood is getting that blood from a non-remunerated regular voluntary donor. So we know this donor has been donating twice or thrice a year, and he's been always tested negative for these infections. And yes, this is the safest possible donor pool. The third is, testing them with the best possible, most sensitive testing strategy. That includes, doing a high quality ELISA, fourth generation chemiluminescence. And if a blood center can afford doing an AT test to pick up window period donors who are infected in the window period. The third part of your question is, doing a donor look back. So now the major issue what in India we have faced is very recently a systemic review was published by the team from transfusion medicine at AIMS, and they evaluated what is the donor notification rate in India. And they reported that up to we are only able to inform 70% of our donors who we found reactive for these infections. So there are 30% of donors who we never are able to connect them because of the wrong number or information which they fill up in their form. And even the 70% of the donors that we connect, only half of them turn up to the blood bank for their counseling. So most of them are either paid donors or they know their status and they don't want to declare it and get registered with a blood bank. So when we are not able to call even donors who are reactive for the infection, tracing back donors who have donated for a patient becomes a very big challenge. And at present in India, there is no centralized data or pool of donor information. People still don't turn up to the calls and they don't come back to the blood bank with a scare that shayad, there is some issue with them. So that is the major reason why the blood banks are not able to do the donor look back studies. But yes, definitely that is one of the best ways to do it, to identify and to establish imputability that whether Hep B, Hep C was because of the blood that was issued from our blood bank.
Thank you, sir. So my next question is to Vikas, sir. When a patient is diagnosed with hepatitis B in thalassemia cases or some other transfusion-dependent anemias, how do we evaluate, how do we further treat, and how do we follow them? And what would be the choice of drugs in children and adolescents?
Thanks, Harry. But you ask just this is not a this cannot be answered in just 1 or 2 minutes. I need just few minutes to explain the natural history of the hepatitis B. So first you have to understand what is the hepatitis B, and because the manifestation in the single patient can be very differently. This can be the asymptomatic carrier. This can be the presentation of like acute hepatitis like illness. And so we have to first understand why these different presentation can be present in a single patients in a different time period and during their natural history. So if the thalassemic patient acquire hepatitis B infections in the early year of life, like in the first 5 years of life, the more like chances they will become asymptomatic. They remain asymptomatic. Their body will not detect the hepatitis B. They will not try to eradicate hepatitis B. The virus will only replicate. The body will not attack the liver. Liver will be attacked only by this immunotolerance in the first 5 years of life, because during the initial 1 or 2 years of life, hepatitis B virus is not recognized dangerous by the toddler or boy and girl in the early age. So body will not attack, virus only will replicate. So during that part, the liver will not get injured. OTPT will not be high, jaundice will not be there, liver damage sign will not be there. So body, you will only detect during the screening, like you will do the annual screening, 6-monthly screening, but the picture changes. When this same boy or girl acquire hepatitis B infections during the later part of the life, like after 10 years or after like in the adolescent age group, the body will detect this as a threat, these infections, and immediately the body will try to eradicate that virus. And during this struggle, during the tug of war, liver get injured. So everything is about how the body react. So if the body react, then it will cause acute hepatitis-like illness. That is a more common after the 10 year of age. So most of the presentations, like if the child received the blood transfusion during the thalassemia and after 3 to 6 months of the incubation period, child immediately develop the hepatitis-like illness. So this is the one scenario. Another scenario, in the first decade of the life, patient acquire the infection during the blood transfusion and child remain asymptomatic. So you have to pick up both the conditions. Pickup is easier when you get because of jaundice, because it is a glare, you can easily pick up. But we have to pick up that period also when the patient is only replicating the virus asymptomatically. So if I come to your case, your child is a 18-year-old child. This child was not acute hepatitis. What is the difference between the acute and chronic hepatitis? Acute hepatitis when there's no chronic replication of the virus. So you should have a reading of single HBs antigen positive with documented HBs antigen negativity 6 months back, as you are in case. You have shown HBs antigen in your case was negative 6 months back in August. Then now in December, this child presented with the jaundice. So most likely this is a picture of acute hepatitis-like illness with no previous history of. Got it? So this is the one scenario. So what is the guidelines for the treatment of acute hepatitis B? So what are the clinical and what are the lab parameters in this patient that depict acute hepatitis B? One is a history of icterus with no past history of HBs antigen positivity. One thing. Second thing is a OTPT is very high, like in the thousands. So this is a acute attack of the liver. Third thing is this child is now, so 2 things is enough, jaundice. Third thing is anti-HBC IgM. So this is a marker of acute applications. So these three findings indicate this is acute hepatitis B. So first of all, we discuss about the management of the acute hepatitis B. So in this case, guidelines say there's no recommendation of antiviral. Why? Because the body is already in a tug of war. Bodies try to control the hepatitis B because body is already having the lot of response. So in that there's already the jaundice. So most likely acute hepatitis B will be eradicated within the 6 months and enzymes will lower down. So no need to start the antiviral therapy. So what are the indications of acute? What are the indications of antiviral in acute hepatitis B? So indications are when the patient is having the encephalopathy during the acute hepatitis, patient is going into the liver failure, INR is more than 2. So if severe acute hepatitis like illness is there, then you should start the treatment. But if the patient doesn't have any coagulopathy means uncorrectable coagulopathy, after 3 doses of the vitamin K, the patient INR is normal. Acute hepatitis like illness, don't start therapy, monitor the patient. If the patient is okay, then most likely the body will eradicate 95% times will eradicate on its own. Acute. Another possibility may be that this patient is positive 6 months back also and now also, and this is a flare. So this is a thing which you should pick because the body will not eradicate on its own because it's a chronic on and off damage to the liver. So what will be that picture? So just next slide. The evaluation part for the hepatitis B. So first is the HBs antigen positive. So you will get the HBs antigen positivity report. So if child doesn't have any feature of the hepatitis like illness in the form of jaundice and another thing, then you need not to do the anti-HBC IgM because that is a marker of the acute illness. You can do the whole panel of the replicating marker, HBE, anti-HBE, and HBV DNA quantitative. This will give you the idea what is the status of viral load in the body of chronic hepatitis. So now we are talking about the chronic hepatitis B. Acute hepatitis B, I have already discussed, no positivity for 6 months. Now in this would have been the scenario when there's a 2 positive HBs antigen. So you have to be careful because you have to start the therapy in this kind of the patient because already the patient is a thalassemic. Maybe the other factor in this patient is the iron overload. So we should be more liberal in starting the antiviral in this kind of the patients because of the thalassemia. So what are the criteria to start the antiviral in chronic hepatitis B? It is not like that if HBs antigen is positive for 6 months, so you should start the therapy in all patients. There's a guidelines. So what are these are the recent WHO guidelines in 2024 March. But they say, so we have to assess multiple factors while starting the antiviral in chronic hepatitis B. One thing is that if DNA load is more than 2000 and ALT is high, upper limit of the normal, at least twice in 6 to 12 months, then you need to start the therapy. There's no confusion. But problem in thalassemia will be that OTPT will be high. So you cannot take this parameter because of the RBC log breakdowns and other parameters. So you cannot take this as a reliable marker because immunotolerant phase when ALT AST is not. I am not talking about a thalassemia. In normal population, if ALT AST is normal, HBV DNA, even it is a sky high, like billions, trillions, then there's no indication of starting the antiviral. Are you getting my point? In chronic hepatitis B, you will start therapy only when patient is having the high ALT AST level, irrespective of DNA level. If ALT AST is normal, DNA is lakhs, million, billions, HBs antigen is positive, no other risk factor, monitor the patient. No indication of the therapy, but there should be no significant fibrosis in the liver. So if the patient comes to you with HBs antigen positive for 6 months, OTPT is normal, no organomegaly, DNA is sky high, so what you will do? Either you will start the therapy or not. So what is the deciding factor whether in this kind of the patient you should start therapy or not? These are liver fibrosis. So you have to assess the liver fibrosis. How will you assess the liver fibrosis? Previously, it was a liver biopsies. But nowadays, if there's a non-invasive testing are there, significant fibrosis in the liver should be there. Then significant fibrosis means more than F2 or more than F2. So what is the cutoff of transient elastography that show there's a significant fibrosis in the liver? That is a 8 kilopascal, 7 to 8 kilopascal. So if it is more than 8 kilopascal, even the OTPT is normal. Then in that case also you have to start the therapy. So first indication is that HBV DNA more than 2000, ALT more than upper limit of the normal at least twice in the 6 to 12 months. That may not be applicable in the thalassemia patient because OTPT will in any case will be the normal. So you have to consider the non-invasive monitoring of the liver. That is also applicable for to see the iron overload also. So there are multiple factors of significant fibrosis in thalassemia like iron overload, hepatitis infections. So this is an important role. So you do transient elastography. If it shows transient elastography is more than 7 kilopascal, then irrespective of a DNA level, irrespective of ALT, you start the therapy. So HBS antigen positive plus significant fibrosis, start therapy. Cirrhosis, F4, forget about the, if more than F2, start therapy irrespective of the whatever the things. There's another thing also, A3, that is also not applicable in the thalassemic patient because this is a AST platelet ratio that is applicable only when there's only the portal hypertension is the cause of the thrombocytopenia. But in hypersplenism, you will not be able to follow this marker. You can only follow the significant fibrosis. Transient elastography का present है, HBS antigen positive है, start therapy. Now another thing, just back. अगर तुम्हारा ये next slide ये है कि अगर सिर्फ HBS antigen positive है, transient elastography भी नहीं है, तो ऐसी कौन सी कंडीशन जिसमें हमें देना ही देना है? जो आपके पर्टेनिंग रहेगा लॉन्ग टर्म स्टीरॉइड मोर देन 4 वीक्स, more than 10 milligrams, आपको देना ही देना HBS antigen positive है. In this also we have divided 3 category: low, moderate or high risk B cell lymphoma. So on that basis, either you have to start the therapy only on the basis of the total anti-HBC or on the basis of HBS and anti-HBC. So the criteria will go down. So in bone marrow transplantation, in stem cell transplantation, you will start the therapy even if the HBS antigen is negative. If so, all kind of the patient going for the liver bone marrow transplantation should have a HBS antigen plus total anti-HBC. So even HBS antigen is negative, total anti-HBC is positive, patient receiving the B cell chemotherapy or stem cell therapy or prolonged steroid therapy should start the therapy, preemptive therapy, because the chances of relapse are very high. In the next slide. So what is the dose and when to stop the antiviral? So entecavir is a drug 0.015 milligram per kg per dose, maximum is 0.5 milligram, age is more than 2 years, and tenofovir 8 milligram per kg per day, maximum 300 milligram. So only problem is that you cannot give the tenofovir in a smaller kit because the maximum tablet is a 300 milligram, but entecavir come in a syrup, so you can give the syrup. And if the patient is having a significant fibrosis, cirrhotic, then should not discontinue the therapy. So these are the things, but next slides.
Thank you, Dr. Vikas. So what I understood is that hepatitis C, any viral RNA positivity
And start the therapy.
Whereas in hepatitis B, there are many more things that make you
should to consider before starting the therapy.
Before you consider treatment. Tulika ma'am, a quick question ma'am. Viral markers we routinely do once in a year. So is that a routine, is that the practice? And are there other scenarios where you will ask for viral markers?
So, am I audible? Yeah, so we routinely do it once a year in patients at our center because we are able to give NAT tested blood. But obviously in between, if there are any unexplained derangements of LFT, patient has jaundice or anything else, then we would repeat it again. When we get new patients who have been transfused outside, and if we're not aware of them, we may monitor them a little bit more frequently at the beginning until they are with us for a longer period of time.
Thank you, ma'am. Another question to Dr. Vikas. Hep C, what is genotyping required for all hepatitis C positive patients? And currently there is a national viral hepatitis control program. So we started getting medicines through that in the last year. So what are the drugs that are for the pediatricians who are out there? what are the drugs that are available through that scheme?
So I can say all children diagnosed with active HSV infection means HCV positive, not anti-HCV. If anti-HCV positive, you should confirm by the HCV RNA.
Yes.
If RNA is positive, age is more than 3 year. Why 3 year cutoff? Because the chances of the spontaneous resolution is more in less than 3 year of age. Should be treated with direct acting approved regimen regardless of disease severity, genotype, whether the infection is chronic or acute. So you should start therapy. So irrespective of genotype, because now recently there are a lot of good drugs that act very well in more than 95% of the negativity rate, and that is irrespective of genotypes. So there are good regimen available. And next slide. So these are the drugs that can be used. So I can say there are 3 combination of regimen for treatment in children. One is a sofosbuvir plus velpatasvir. Another is a sofosbuvir plus declatasvir. Third is a sofosbuvir plus ledipasvir. There's a dichotomy in sofosbuvir plus declatasvir in WHO and ASLD. WHO say you can give in more than 3 years of age, but ASLD say you cannot give in less than from 3 years of age. You should be give from 8 years of age. So there's a dichotomy. So I will say the safest combination you can give is sofosbuvir plus velpatasvir, because this is you can give in any genotype. It is available in National Vector Program Control, but the dose you will not get. Dose is 400 and 100 milligram. So you can make it half, 200 or 50, but you cannot make it 150 milligram, because in the less than 70 kg, the dose is 150 milligram, and the adult tablet is a 400 milligram. So you can make it little bit toward the 200 milligram, you can make it half. So safer drug is a Sofos plus velpatasvir. I think Decla is available in.
Yes, that also.
Decla is available, but you cannot give in the children because there's a lot of research is going on. So I think till now the more literature comes, you can give the Sofos plus Velta in these kind of the patients.
And viral RNA testing is also now freely accessible.
Yes.
Freely available through the program.
12 weeks of the therapy, you should do the RNA level after 12 weeks, immediately after the stoppage of the therapy, and for after 12 weeks of the stoppage, to look for the sustained virological response. So 2 RNA should be done, one after 12 weeks and another after
another 3 months.
12 months. And one more point, if the patient has already received inadequate dose of these drugs, then the therapy or interferon, then therapy should be considered for the longer duration, 24 weeks. So.
Thank you. So, Dr. Satyam, NAT testing is what we are ideally providing for our patients. So, but in your experience, how much does it help? One, and second is many centers give mini pool NAT, so to reduce the cost implication. So, what is the actual difference in the cost between ID NAT and mini pool? And is there a middle path for smaller centers to follow? Because it's so expensive, many centers are not able to adopt it.
Yes, so NAT, one of the first indication to use NAT is to pick up window period donors. The other one is to even pick up occult hepatitis B, donors, which we are not able to pick them for surface antigen detection. One of the most important factor to decide between ID NAT and mini pool is done in the Western countries where there are low endemicity of hepatitis B and C. As compared to India, there are pockets in India which are high endemicity, and overall India comes in the medium endemicity of the hepatitis B infection. So ideally, our country is not ideal to be used for mini pool testing, though many centers are using mini pool for various reasons. For cost, obviously, one of the major reason. And very interestingly, the company which introduced the mini pool in our country is now coming back with ID. So even there is a change of trend to come back to ID, since that is more sensitive to be picking up these infection. And most common infection that we pick up is obviously hepatitis B, as the incidence of Hep B is more. As far as one of the best strategy is going back to non-remunerated voluntary blood donor. So if you have a repeat non-remunerated voluntary blood donor who is donating with you in your blood bank at least 3 times or 4 times in a year and is always tested negative for these infection, is the safest possible donor, which is even the best way of selecting a safe blood, even when you don't need to do NAT or any bigger testing on it. So yes, that is the best strategy. Sadly, in India, most of the peripheral centers and district blood banks and even good standalone blood centers in Delhi NCR are doing rapid testing. So rapid testing is relatively less sensitive and which does not pick a lot of infections. And that is one of the main reason why, like in during COVID, patients were having transfusion from wherever they were getting blood. And that actually increased the incidence of TTID in these patients. And even post-COVID, even it is reported in from the West and in our country, we are seeing resurgence of these infections. Syphilis has been picked up again. There were years we were just picking 1 or 2 syphilis in our donor population. Now we are practically picking syphilis 1 or 2 donors every month. And that is reported from a lot of other centers. So we are seeing another resurgence of these infections in donors because of the disturbed healthcare system that we had during the COVID.
Thank you, Dr. Satyan. So one good way is to tag certain donors to certain patients. Like you said, if you know trusted donors and 15 donors can you tag to. So I think we are really running short of time. So it's a last case for today. I would request Dr. Silky to discuss the question and the case and the pertinent questions. Over to you, Dr. Silky.
Good evening, everyone. So I'll try to be a little quick in the interest of time. So discussing case of our adolescent female thalassemic girl, 14-year-old girl who was diagnosed at 1.5 years of age and was undergoing transfusions elsewhere. She got splenectomized at 10 years of age. And she presented to our institute at 12 years of age, that is 2 years back. Now the girl is 14 years old. And she, on presentation, she gave this interesting history of tetany whenever she used to undergo transfusion. And for the same, she used to receive IV calcium supplementation. So for that, she was evaluated and was found to have normal levels of PTH. Although the calcium and vitamin D3 levels were found to be low. So she was started on oral calcium and vitamin D3 supplementation, and she responded very well with no recurrence of tetany thereafter. The next slide. So this girl continued transfusions with us with optimal pre-transfusion hemoglobin, and she underwent transfusion every 3 to 4 weeks. She had a Tanner stage of 3 and achieved Minaki at 13 years of age. She also, recently in December 2023, last year, her ferritin increased to 10,900, which was very, very high. Also, the T2 star MRI revealed severe liver iron overload and moderate cardiac iron overload. So in view of this, her chelation, oral chelation was optimized and the following values improved. So recently, just last month, this girl presented to us with history of polyuria and polydipsia and significant weight loss of about 5 kg over last 2 months. There were no vomitings or altered sensorium, and her random blood sugar level was found to be 667 with a fasting blood sugar level of 515. So it was very high, but she was not having any features of diabetic ketoacidosis. So she underwent evaluation. We gave a endocrinology consult and evaluated the patient with the hormonal profile. The HbA1c was found to be quite high. It was 14.2%. Though the fructosamine assay was advised, it could not be done due to logistic reasons. The morning serum cortisol was 24.9, which was borderline high. The thyroid function test was within normal range. So a diagnosis of diabetes mellitus was made, And this girl was started on insulin, long-acting glargine insulin and short-acting insulin based on the sliding scale. So this girl took a very long time to respond in terms of sugar levels. We gave very high doses of insulin, but still, I think her sugar levels hovered around 500 until about 10 to 12 days after we started insulin. So ultimately, we had to add metformin, and the euglycemic status was achieved only after 2 weeks of starting the treatment. Currently, well, continuing on insulin as well as metformin. So the first question I would like to ask Dr. Tulika ma'am. Ma'am, can you please tell us when is the ideal time to start evaluation for endocrinopathy? At what age should we start that in thalassemia, in transfusion dependent or in non-transfusion dependent thalassemic patients? And what tests should be advised and how frequently should they be done?
So we send our patients after the age of 10 years to the pediatric endocrinologist. And we do that both for the thalassemia patients who are transfusion dependent as well as the non-transfusion dependent. Because in the non-transfusion dependent, the iron overload is due to non-transferrin bound iron, which is actually even more toxic than the transferrin bound iron, which the patients get from the blood transfusion. So we started 10 years and we have an expert, Dr. Anju Seth, who's with us. So I think I'll hand over the question to her because I think you will be more interested in listening to what she says.
Sure, ma'am. Dr. Anju, ma'am, your comments.
Thank you. So as Dr. Tulika said, 10 year is a standard recommendation. At our own center also, we start seeing all these children at 10 years of age. In fact, there were times when just a few years ago, we had children coming from outside who were really, far too advanced. But once you start at 10 years, what we do is their growth monitoring. We do a growth and puberty assessment. We do the basic endocrine screening, which includes a fasting blood sugar, which includes calcium phosphate, ALP, preferably in a fasting state. Many times it's not possible. We would do a thyroid function. So thyroid, calcium, and blood sugar is done, and a clinical assessment for growth and puberty and a bone age. And this is an evaluation we do every year. We do not, as of now, do DEXA for every child, but in case of, say, chronic backache, or if they end up having other endocrinopathies like hypoparathyroidism, we would recommend DEXA also, or of course, if there's a fracture. This is an annual screening. Over from my side on this issue. Yeah, coming to tetany. So this child is interesting. The very fact that every time with blood transfusion there is a lowering, there's a tetany, indicates that her blood calcium levels were anyway very borderline. She was just about managing, and the moment you give her transfusion and with that calcium citrate being formed, the levels were falling below the critical range, and the child was developing tetany. But looking at your reports, you say there was a low calcium and there was a low phosphate and PTH was normal. Let me tell you, and vitamin D was also low. When calcium is low and vitamin D is low, normal PTH actually indicates relative hypoparathyroidism, because a low calcium is a very strong stimulant for PTH production. So presuming PTH has been measured correctly, a normal PTH in presence of hypocalcemia indicates hypoparathyroidism. Why I said presuming PTH is measured correctly, because PTH is a very fragile molecule, needs to be collected in a cold syringe, has to be cold centrifuged and immediately transported over ice to the lab. To measure it in plasma, take a sample in EDTA, centrifuge and send, or else you freeze it. If you just take it like a routine sample and leave it for the lab to assay as a routine sample, surely PTH will get destroyed and you will get falsely low values. So in this situation, it is very likely the patient has some hypoparathyroidism also. But also we should remember, in our country, vitamin D deficiency is very common, and in adolescents, vitamin D deficiency can also give rise to symptomatic hypocalcemia. In your case, the child had low vitamin D and responded to giving vitamin D and calcium. So it looks like for the time being, the issue is taken care of. But keeping in mind a low PTH level and presuming it has been done correctly, I would watch out for hypoparathyroidism, because hypoparathyroidism is reasonably commonly seen in patients with thalassemia. It's a common endocrinopathy. So one would normalize the vitamin D level, and if probably do his PTH again. If PTH again comes to be low, or if the child continues to have tetany, or if the phosphate levels are high, that would be another indicator. One would look for hypoparathyroidism. And how would we manage? What you did was great. If because the child was having vitamin D deficiency, you treated it, the child is well. But the other scenario, if the child develops hypoparathyroidism, we would have to give this child active form of vitamin D, not cholecalciferol, but calcitriol with a oral calcium supplements, carefully monitoring the urinary calcium creatinine ratio and maintaining serum calcium in a low normal range. I think, and also don't forget measuring serum magnesium level, that can also contribute towards hypoparathyroidism. I think that is all I would say for this
Yes,
question.
now I had a doubt. So in this
Yeah.
case, when there is parathormone, if it is normal, you
Yeah.
would switch to activated vitamin D3 anyway, right? And
What you did, look, what happened was you gave vitamin D and the child was well. So presuming that serum vitamin D is normal and the tetany problem is taken care of, I will not do anything else at this stage. What will indicate presence of hypoparathyroidism in this case is, of course, if the tetany keeps recurring, or if the child has elevated serum phosphate level, especially in the fasting state. That would be a trigger to measure PTH again, because hyperphosphatemia should not happen in vitamin D deficiency usually. So in such a situation, I would again measure the PTH level, and in case of a fasting hyperphosphatemia, and if PTH comes low with an elevated phosphate and low calcium, then we would presume it is hypoparathyroidism, presuming magnesium is normal. Again, because magnesium can also give rise to low PTH levels. Normal magnesium, low calcium, high phosphate with a low PTH is what is hypoparathyroidism. And we'll give active form of vitamin D in that situation, calcitriol, along with calcium supplements.
one more doubt, ma'am. When do you consider recombinant parathyroid hormone in
We
thalassemia?
don't consider recombinant parathyroid hormone at all.
Not at all. It's because TIF guideline, it somewhere says in that, that if it's not responding, then it can be tried. So
We've never had the need, because hypoparathyroidism would respond very well to calcitriol, and just monitoring, as I said, urinary calcium creatinine ratio and serum calcium in the low normal range, because you don't want the patient to end up having hypercalciuria and having renal problems because of that. There is no need for recombinant. It's so much more expensive. Why give it? Teriparatide has been used experimentally for osteoporosis, not for this situation.
Tulika ma'am, are you saying something?
No, I agree. We've never had to use it. So I agree with Dr. Anju's recommendations.
Thank you, ma'am.
So the next question, again to Anju ma'am. So we discussed about this child developing diabetes mellitus, which responded very late to the treatment. So for screening of diabetes, ma'am, in thalassemics, what is the most appropriate test which should be used? Is it a glucose tolerance test or HbA1c or the fasting blood sugar or postprandial blood sugar? What would you recommend?
Okay, so what we use at our center, and we have been very happy with that, and even most guidelines would suggest that let us just measure fasting blood sugar. Because what happens in these patients is usually they first develop impaired fasting glucose. Impaired glucose tolerance usually comes up later. In fact, in a recently concluded study as a part of a dissertation at my institute, we had nearly 1/3 of our patients with thalassemia who had impaired fasting glucose, whereas impaired glucose tolerance was present only in about 10%. And all those who had IGT also had impaired fasting glucose. So FBS alone is good enough. But if fasting blood sugar is more than 100, in that situation, one would like to go ahead with the OGTT. Okay. And
Yes,
there was, I think you had some other part of that question.
Is it? Okay.
HbA1c is not needed. By the way, this child, it's a little unusual because usually we would pick up these children on testing. And this kind of high blood sugar in this child, it's a little unusual. Most patients with purely thalassemia related diabetes, all that we have seen quite a few of them, don't present with such high levels. I wonder if the child has a component of type 1 diabetes here. And that would be because that is what would present with such high levels. And of course, there is an insulin resistance in patients with thalassemia. So are we dealing with a situation where there is type 1 diabetes combined with insulin resistance, both together causing very, very high levels of blood sugar at presentation and difficult to control? It's a possibility because I've not seen such high levels purely in thalassemia and presenting in such a catastrophic way.
And how frequently do you screen, ma'am, for adolescent thalassemia, for FBS?
It's part of annual screening, as I said earlier. It's part of, yes, annual screening. And unless, of course, a child has symptoms, then one would repeat at any time.
I think we have really run out of time. One quick last question to Dr. Tulika, ma'am. Ferritin versus MRI. We have been sending all our MRIs to All India Institute thanks to the new technology that has been developed there for MRI, T2 star. So, so we have seen that it does not correlate at all. So what is your experience, ma'am, and how frequently do you recommend MRI?
So MRI, if it is abnormal, you can change your chelation. But the MRI imaging will not change very rapidly. So it may take 6 months or so for you to see a change. MRI is, so it's very good, but I think doing it more than once or twice a year, it's not the right thing to do. Ferritin, as you know, is an acute phase reactant. So if there's any inflammatory condition, liver disease, renal failure, metabolic syndromes, all of these things will increase the ferritin. So sometimes it can be high and it may actually not be, that important. But looking at the trend is useful. And once or twice a year, a cardiac MRI, I think, is the way to go. More frequently doesn't really help. But I think more important than that is we need to start it early. And we need to make sure that we modify the chelation according to the report.
Thank you, ma'am. So I think we'll wind up the session. So we, again, I would like to thank all the collaborators for this webinar today. We have AOP Noida, who is joined in today, Dr. Subhash Chandra. And I'm not sure if sir is still on the call. If yes, kindly unmute yourself. And that's Dr. Sandhya. I would like to request Dr. Sandhya or Dr. Subhash Chandra to kindly propose the vote of thanks, and then we'll wind up. Thank you. You're muted, Dr. Sandhya.
Thank you, Dr. Neeta. Dr. Subhash had to leave for some emergency. So,
I have joined.
Sir,
Thank
great.
you.
Please go ahead.
Good evening. Good
I
evening,
was there
everyone. Yes. So thank you very much for all the panelists and the organizer who have nicely organized this program. And I have learned a lot from this, all these information which has been discussed over here. And Dr. Chandra, Jagdish Chandra, and the panelists all has given the insight very beautifully and very nicely and very simplified. Just one comment I want to know from the panelists, that do we have any data that we get the consent, written consent that your child may get this hepatitis B, chances are this, HIV chances are this, hepatitis C chances are this. So do we inform them in written?
Yes, I think I'll answer. Yes, for every transfusion, there is a signature taken. I think Dr. Satyam.
Do we inform them that your child can get the hepatitis B infection during this transfusion?
Definitely. Safe blood.
Or HIV also.
Yes. We discuss with them regarding safety of blood, which is a very, very important criteria in these regularly transfused children. And that we encourage them to take blood from blood banks that are safe and not from voluntary donors and smaller blood banks that we just heard Dr. Satyam regarding the rapid testing. It is extremely dangerous and it misses a lot. So that is always told to them. And every blood transfusion, if you see that blood bank gives form with it, which has a consent form, which clearly mentions transfusion transmitted infections.
Thank you. Thank you, Dr. Neeta.
Thank you
So-
again from my side. Thank you, Dr. Subhash Chandra. Thank you, Dr. Sandhya, Dr. Tulika ma'am, Anju ma'am, Dr. Jagdish Chandra sir, Dr. Vikas, Dr. Satyam, and all my team here. Dr. Revati ma'am, she had to leave early. And thank you again for a wonderful webinar. We'll be sharing the link once it is uploaded on YouTube. We'll share it again with all of you. Thank you again. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Wonderful
Thank you so
program.
much.
Thank you.
Thank you all.